Good morning, everybody. Buenos dias a todos. Magandang gabi, mayong gabi ninyong tanan. Xin chào to all of you from all over the world, of all our participants. Thank you for joining us today. And in a few minutes, we should have Dr. Q to start our symposium. But before we start, just like to remind everyone that there won't be any breaks in between and speaker, except for the 5-minute question and answer after the presentations. And attendees can type in their questions in the chat box during that time. In order to be respectful of the time differences, we would like to be able to stick with the schedule as much as possible. So thank you all very much once again, and I would now like to hand it over to our president, Dr. Alfredo Quiñones-Hinojosa, for his opening remarks.
Gracias, April. Thank you, everybody. Wonderful to have everybody here today, and I am just honored to be with all of you in such an unprecedented times when so many things are changing around the world. And if anything, this pandemic has taught us that we are being more connected, and the world is also getting smaller as we move. It is interesting that as we try to distance ourselves, if anything, is making us come closer together through these global disruptions. So today we have an amazing program that our team has put together for you, for all of you around the world. I am blessed to be part of this team as I look at the organizers and as I look at the people who have made this possible. You'll see we have speakers from all over the world and all over, the disciplines. And we'll have them present some of the work that they're doing, how they rise to this challenge that we have had and during these times, what they're doing, how they're coping with it, what kind of things are going on. And hopefully through this work, we'll share with you some of the hope and some of the dreams that we have to continue to empower, to educate, and to help those who are less privileged than some of us are to receive amazing care at some of our institutions. So as you know, Mission Brain is dedicated to building bridges, to changing the world, to give the world and those who live in it hope. And that's exactly what our team is doing. And you see the speakers that we have right here. In the meantime, we are proud. One of our organizers here, Andres, was the first recipient of our international fellowship. And he is Dr. Ramos-Fresnedo, came from Mexico City, finished medical school in Anahuac. And his dream also is to become one day a brain surgeon. And I have no doubt that that little seed that we planted today by giving him the scholarship is going to become an amazing person for service that he's going to give to the world. So we're excited about this. This is a new program that we have launched. We will have more. You'll hear more about this, and hopefully these doctors are going to help us build more bridges. I want to thank JJ, Ryan, April, Lisa, and Carla, obviously, for putting all this together. And here, right in this room, we have some of our fellows, Paola Mead, and of course, Andres, who is here organizing this as well as helping and putting it all together. They're really the unsung heroes, and they're going to be coordinating, and April and Lisa are going to keep us all on time and excited about this. I wanted to share with you just some of the things that we heard. Kai actually was one of our residents when we first started back in 2010, 2011. He was at Johns Hopkins. He is now a full professor at the Mayo Clinic. And you can see what he said. And I think that this is an image actually that Carla made about our brain, about hope, bridges, unity. But Kai says that that experience with Mission Brain has truly been life altering. It is invaluable to be able to see how different hospitals, cultures, countries take excellent care of their patients, and to be able to provide what I know and learn from these other institutions in order to move the field of neurosurgery forward. This has been the highlight of his career, he said. This goal is to eradicate barriers, whether it's financial, political, or geographic, so that patients everywhere around the world can receive the best neurosurgical care possible. So I thank Kai for saying these amazing words. This is Veronica, one of our extraordinary supporters from Mexico City who said, as a Mexican, I feel extremely proud for what Mission Brain does. Not only they perform pro bono surgeries for people that are not able to afford them, but they are an example of how much you can change a person's life for the better with hard work, team effort, and most importantly, with a lot of love and hope. And finally, Olu, one of our residents, he's now spending time in the laboratory, originally from Nigeria. He came to Monterrey a couple of years ago with us. He said, the greatest moment of this trip was seeing the appreciation on the faces of the families and the post-operative period after their loved one had been unable to obtain care for so long. It is truly remarkable, he says, to be able to touch lives in this way, thanks to the collaboration of the hospital administration, surgeons of Crystal Muguerza Hospital, and the Mission Brain team. There is no greater gift than life. And those are the words of our supporters of the people. So I welcome everybody. We have an exciting program. I'll give it back to April and JJ and Lisa. Take it away. We're very excited to be with all of you here today, and we look forward to building more bridges. Thank you.
Thank you, Dr. Quiñones. My name is April Sabangan. I'm the Executive Director of Mission Brain, and I will be moderating the first half of our symposium for today. To follow that very inspirational opening remarks is going to be Dr. Theodore Schwartz. He is the David and Orcel Barnes Endowed Professor of Minimally Invasive Neurosurgery and a Professor of Neurosurgery, Otolaryngology, and Neuroscience at Weill Cornell Medical College in New York Presbyterian Hospital. He is also the Director of Anterior Skull Base and Pituitary Surgery, Co-Director of Surgical Neuro-Oncology, and Director of Epilepsy Surgery, and runs a fellowship in Minimally Invasive Brain and Pituitary Surgery. We'd like to welcome him here today. Good morning, Dr. Schwartz.
Good morning. How are you?
Fine, thanks. So I'll give it all up to you in your presentation.
Good morning, everyone. I just want to say it's really a pleasure to be speaking to you today. I've been involved with Mission Brain for several years, working with Dr. Q and Mike Lawton, and it's really been a pleasure. I've gone on many missions, my children along, and it's really part of my life now, and I hope to continue to be involved. What I want to talk about is a little bit of the experience we had in New York City during the COVID-19 pandemic, some unique things about New York and how we responded, and in particular focus on endonasal endoscopic surgery. So as you all know, New York City was really hit very, very hard by the COVID-19 pandemic. And early on, we had an enormous number of cases that really overwhelmed our healthcare system and dramatically impacted our practices. New York, as you can see here, was peaked above even Lombardy, Italy. This is at Cornell, Weill Cornell, New York Presbyterian Hospital, where I work. And this shows you the number of cases that we saw and the number of cases that went into the ICU over time. And as you can see, there were over 2,000 cases, and on a ventilator, we had literally at one point in time almost 800 cases. So you could imagine our entire hospital was turned into a COVID hospital. Every ICU was a COVID ICU. Every OR was a COVID ICU bed. We had 4 patients in every ICU. So it really was a dramatic transformation of our hospital. It was extremely scary to be there at that moment in time, and it wasn't clear whether we were going to have enough beds in the hospital to serve the community. This just shows you a list as of April 29th, and we keep recording this, and I'll show you more recent data. But at that time, we had admitted almost 10,000 patients with COVID in our system, and of those, almost 2,000 had passed away. So quite a large 20% mortality rate, which was also pretty terrifying. So where are we now? You can see these numbers now: COVID positive patients, COVID patients in the ICU and on a ventilator. As of just a couple of days ago, we had maybe 70, 80 patients in the hospital, only 17 in ICUs and only 13 on ventilators. And we haven't yet really seen a second wave at New York Presbyterian Hospital, and we're much more under control at this point. So what we were faced with was initially these reports that doing endonasal endoscopic surgery on patients with COVID-19 was incredibly dangerous, not only to the patients, but to the healthcare providers. And there were reports out of Wuhan that one case in particular, a number of healthcare providers had gotten sick operating on a pituitary adenoma who was COVID positive. And a lot of the healthcare workers got sick and some of them died. And then subsequently, there was this report that came out showing that that was not actually the case. And it's unclear if this was doctored or not. But there was an enormous amount of fear, and there clearly is risk of aerosolizing the particles. And that's really what I want to focus on and talk about in this talk. How did we respond to that? The first thing we did was figure out how to carefully and adequately don and doff PPE. So I was involved in some committees that were made these sheets to give to all the surgeons so that we knew if we did have to operate on someone who was COVID positive, and obviously we did this on all the patients initially when we couldn't test them, the exact sequence of events to don and doff your PPE in a safe way. And it's actually fairly complicated to do it correctly. And so these were posted up on front of all the ORs. And we had 4 ORs that we saved that where we built negative pressure antechambers. And I'll show that to you in a second, where we could safely operate on these patients. But then we had to figure out how do you choreograph the entrance and exit of those operating rooms for COVID positive patients. And so we went through and created, this was a committee I was on with several other surgeons from other committees, how exactly to bring the patients in safely. And it's very complicated to get them into the OR through the antechamber and have everyone leave at the appropriate time, wear the appropriate PPE, which needs to be donned and doffed, and then intubate the patient and leave the OR so the anesthesiologist intubates the patient, because that's clearly the highest risk procedure, and then get the surgeons back into the OR once they're positioned in a safe way to actually do your surgery. Similarly, exiting the operating room is fairly complicated, and we had to choreograph detailed steps as to how to leave the operating room and use the antechamber in an appropriate way to safely operate on patients who may be positive, God forbid, if you had to do an emergency. But that didn't take away from this fear. And the idea is that COVID-19 or SARS-CoV-2 clearly has a predilection for infecting the mucosa of the upper and lower airways. The viral load is very high in the nasal cavities, pharynx and oral cavity, and airborne transmission occurs during transmission of small inspirable aerosols, which are usually less than 5 microns. And I just want you to remember that, less than 5 micron size. And the pathogens sort of glom onto that and then transmit. And once they're airborne, the aerosols can remain infective over time. They can spread long distances. And so you have to really, really be very careful about how you manage those patients. So there's a difference between droplet transmission and aerosolization transmission. Droplets are greater than 5 microns, and those go directly from person to person and then fall quickly on the floor. And droplet influenza virus, rhinovirus, SARS-CoV-1 was all a droplet. But it's not clear the distinction between droplet and airborne, and there is some overlap and some uncertainty. But although SARS-CoV-2 is primarily droplet, there are procedures we do which can aerosolize the particles and make those particles smaller, and that's drilling within the nasal mucosa. And once aerosolized, COVID-19, SARS-CoV-2 may remain viable in the air for at least 3 hours. And that's obviously very scary, particularly when we're doing endonasal surgery. So a couple of papers came out, and letters in particular, saying that protecting the surgical team from contracting COVID-19 is of utmost importance. They're both a potential vector for patient contamination and a scarce resource that cannot be easily replaced. The most prevalent risk faced by neurosurgeons is an airborne transmission of the virus resulting from the use of aerosol-generating instruments, which include power drills, tissue shavers, electrocautery, lasers, and ultrasonic aspirators. So to be infectious, aerosolized particles need to contain virions, and this is definitely the case in the respiratory tract. This is out of the ENT literature for patients who test positive for COVID-19. Minimum level 2 PPE is required. And so that's an N95, a respirator, gown, double gloves, goggles, face shield, head covers, all the stuff I showed you initially. And for long duration procedures, such as endonasal endoscopic surgery, level 3, such as PAPRs, really are what are recommended. And those are those hoods with positive airway pressure that gets pumped into the hoods to keep virus out of there. Now at Cornell, and while New York Presbyterian, we did not have any PAPRs. We were not allowed to use PAPRs, and it's actually very difficult to operate with the PAPR on. So what do we do now? Well, we preoperatively test all our patients, but the problem with pre-op testing is we all know there are false negative tests. There are new unknown viruses for which no tests exist. Seasonal flu can come around for which routine testing is not performed. We have negative pressure operating rooms with HEPA filters, but many hospitals do not have these, which also can be a problem. And operating in full PPE or with PAPRs is very difficult. You know, it's hard to communicate. It's hard to breathe. It's hard to feel comfortable. And it's exhausting, and you're sweating. And so if we could avoid that, that would be terrific. So these were some solutions that we saw: transnasal management of endonasal endoscopic with some plastic over the nose. You know, this is not necessarily ideal. We also are thinking about the fact that seasonal influenza virus comes around every year, and approximately 300 to 650 respiratory deaths occur just from seasonal influenza virus. And now we start thinking maybe we're aerosolizing that into the room as well. So endonasal sinus and skull base surgery has a high risk of aerosolizing particles. This is a problem. Preoperative testing is inadequate due to asymptomatic carriers, lack of tests of every known infectious organism, false negative tests, and full PPE is difficult to wear. So we needed to develop a device that could be placed over the patient's face to decrease the aerosolization of particles, both known and unknown, that didn't interrupt the workflow. So we could see, we could maneuver, we could use instruments of the correct length. So we developed this negative pressure antechamber with a transparent acrylic shield, an operative port covered by a translucent silicone diaphragm, a rigid frame. We could attach a suction to that, and then a silicone gasket that we could operate through. And this is a patent that we put in. We made 3 sizes to fit all size faces, small, medium, and large. And we worked with biomedical engineers at Cornell in order to develop the appropriate size faces. So this is what it looks like. We made it out of a couple different pieces. We're working on some modifications now for our FDA approval, but it fits right over the face. There's a silicone diaphragm that you can operate on. And there's also grooves for the endotracheal tube. Right here, you can see there's a little groove, and also for an orogastric tube. So first we tested it in some models in the laboratory where we're drilling the ribs of different animals, and we're measuring particles and putting different degrees of vacuum on the device. And the vacuum attaches to the top of the device. And what you see is that on the left, what we're trying to get is a minimum required 0.38 meter per second flow. And in order to do that with the diaphragm on, we really don't need that much pressure, -1 millimeter of mercury. Whereas without the diaphragm, with the whole opening, you need quite a bit more pressure to get that level, 15 to 20, which is why we decided to use the diaphragm. And if you look at aerosolization of particles that are 1 to 5 micron or less than 5 microns, or greater, excuse me, than 5 microns, with and without the diaphragm, both worked pretty well. We were able to eliminate the particles. But again, this is a laboratory model. The other thing we found was that if you put an instrument in through the silicone diaphragm and move it around, it does increase the aerosolization of particles. But if you increase the negative pressure, then that doesn't matter anymore. So that also was important to figure out what was the amount of negative pressure we needed for this to work. So the cadaver head, we also did this, in a cadaver head, measuring particles of different sizes. And for particles that were 1 to 5 microns, you can see that compared to baseline, without the antechamber, there was a very, very high level of aerosolization. But when we put the antechamber on, both with and without the diaphragm, we were able to reduce aerosolization of those size particles. We then used this mask in a series of 6 patients of various pathologies with endonasal endoscopic cases, and we could actually measure the particles that were emitted. So this just gives you a sense of what that looks like. This is the first device we had, and I want to call your attention to the suction you see here. So we're attaching the suction to the top, and that really sucks the fluid out. Here we have a small opening, and we modified this. This was one of the original prototypes, but it has to be sucked into a HEPA filter. So this is a Neptune device, which sucks the air out. This shows you us operating with the face mask in place. And this is on the right, you can see the silicone diaphragm here. So you can just cut out small holes to operate through, and you can tailor those to the surgery you happen to be doing. So if you measure the emission and the aerosolization of particles, this is now in vivo in humans. What you see is that baseline is a very low level. This is less than 5 micron particles. This is without the antechamber. You see a very high increase. And of course, with the antechamber, both with and without the diaphragm, the aerosolization of particles went down to baseline. And on the right, you see particles greater than 5 millimeters, not as important for viruses. But this just is a proof that, in fact, this device does work. It achieves what we want it to do. Sorry for the writing there. Let me see if I can erase that. So we also modified the device. We sloped it to get the hands closer. We changed the size of the window to make the device easier to use. This just shows you the final CAD drawings of the device that we developed. This shows you the final product. We found this to be the most useful and efficacious, and this is the one that we're going to try to get FDA approved and mass produce so that we can make it available to other healthcare providers. There are some other devices out there. These don't provide negative pressure, so probably are not as effective. This is one that does provide negative pressure that was described at Emory. This would be another device, but again, it's only over the nose, not over the face. There's some limitations to this. You can't really see where the nose is. And so we feel our device does work a little bit better. And this one also has never been tested with particle size as ours was. So in conclusion, endonasal drilling causes aerosolization of particles from the respiratory mucosa that presents a risk to healthcare personnel. A negative pressure facial antechamber is a viable solution to remove aerosolized particles, rendering surgery safer to the OR staff. And in principle, such a device should be used for every aerosolizing procedure to reduce transmission of known and unknown infectious particles. We know about COVID-19. We obviously don't want to spread that, but there are going to be new diseases coming through, possibly new pandemics, new viruses. We have influenza virus every winter that we're spreading through the ORs. And if we use this device, we could save and preserve the health of our healthcare providers. Thank you very much.
Well, thank you very much, Dr. Schwartz. That was such an amazing presentation, and we will go ahead and take questions at this point. I think we have one question already. The first one is if this is a disposable device or is it modular, and are some pieces disposable?
So, good morning, by the way, April. It's great to see you. It's been too long.
Yes.
We, have been working with some groups that have been telling us how best to get FDA approval for this and what's required. And I think what we've ended on is that the whole thing should be disposable and sterile. So it would be a single-use device. It would be fairly inexpensive to buy. That doesn't mean that it couldn't be reused, but I think for the safety of the company and the safety of making sure that no diseases are transmitted by reusing a device from patient to patient, the safest thing is probably to make the whole thing disposable and the whole thing sterile.
And Ed, just thank you very much. That is a beautiful and inspiring. I put some comments right there. That was my question about the disposability and, obviously the fiscal responsibility. How do we make these things affordable for, places? Of course, at a place like yours in New York or us at the Mayo Clinic, these are the things that we could potentially do. and making this possible. But the rest of the world, it's challenging, right? These things can get pretty expensive. What do you think is the cost you estimate of making the device? And of course, the market value is different, but what are your thoughts about that?
Well, we were able to 3D print a device like this for about $14. So it really was not that expensive. And you probably could reuse it, right? And you probably could just change the diaphragm, the silicone diaphragm. You could make one little part of it sterile. There are ways to do it much more cheaply. And that's why we did the tests with and without the diaphragm. But what we may have to do in the United States could be different than what you could do elsewhere. And you also could jerry-rig something and make your own device that's similar to this. The key is that when the suction has to be filtered, you can't just suck it into a suction, because the virus would then get into the suction canisters and be released in the operating room anyway. So as opposed to there being filters within the device itself, a lot of places have a suction device with a HEPA filter built in. And if you can get that, then you can suck the particles out and get them filtered externally. So that's really important to making this safe. It's not just about the suction, it's about filtering afterwards.
And there's a question right here, that a very good question from Gerardo. He said, how many negative COVID tests do you require before a transsphenoidal surgery? That's the first part of the question. The second one is the following. If the patient is negative for COVID, but obviously was positive, some time ago, do you think that you still need the negative pressure device? So what are your thoughts about that?
So the first question is, what do we do at Cornell now? We do one test for every neurosurgical patient 3 to 5 days before surgery. If they're negative, we proceed. The hospital has recommended that if you do any aerosolizing procedure, you wear full PPE. And obviously that's because they don't 100% rely on that test to be 100% sensitive and specific. So our thought with this device is that this should be used on every patient, regardless of COVID or not, because first of all, COVID testing is not perfect, it's imperfect. Second of all, even if the patient doesn't happen to have COVID, they may have another infection. They may have influenza, they may have another virus. They may be carrying something that they're resistant to, that you're susceptible to, and that some other healthcare worker is susceptible to. And every year there's going to be influenza viruses that are going to be spreading through the community, coronaviruses, rhinoviruses, multiple types of viruses. Some people think the coronavirus we have may become endemic. It may never go away. And there may be the possibility of reinfections with our current coronavirus. So the safest thing to do really is to use a device like this. If it's cheap, if it's affordable, on every patient that we operate on. And that is our hope going forward, because there's going to be so much uncertainty as to whether our patients really are infected or not. And I think this pandemic has raised our awareness. I don't think we were really thinking about it ever in the past. What can we get from our patients by drilling into their nasal mucosa? And the truth is, we probably get a lot of things from our patients by drilling into their nasal mucosa that we never really thought about in the past. And God forbid there's another pandemic that comes through in another 10 years. We may not be prepared for it without devices such as this.
And we know for sure, Ted, there's going to be more pandemics, no question about it. And this is what I'm so excited about, this device that you propose right here, the way that it's organized, the possibility that it's modular, the possibility that some of the stuff can be disinfected and make it fiscally responsible. But at the end of the day, I think the point is that the filter, that has to be very, disposable for sure. There's another question right here from Rodrigo, Rodri from Guadalajara. He says, great proposal. He goes, do you have some results related to the risk of infection in the surgical team in the follow-up? I would imagine it's negative, but I guess we just wondered, we saw the particles, we saw how clean they are in the cases that you did. But any issues that anecdotal or data?
Yeah, no one that I know of has been infected, but I think a study like that would be much too difficult to do, because there's only a small group of us that are doing these procedures. And, a lot of us, you'd have to decide whether somebody happened to get infected down the line. Nobody's really gotten infected down the line. And I think it'd be very difficult to design a procedure like that, because your rate of infection is going to be potentially so low that you'd have to do really thousands and thousands and thousands of patients to figure out who it prevents from getting infected down the line. I just don't think that's a feasible study. We can show efficacy based on particle size to show that it does what we think it's going to do. But I think with the end result of preventing infections, that it would be a long-term, multi-year study. And it'd be very hard to control for that also.
What you were able to control is that data that we were able to collect, and that seems to be very tight and very good. And I think that's as good as probably, as you said, that you can do, because there's so many other variables. Let's see if we have any other questions right there, April. Any, I see Ramiro is connected.
We have one more question. And I think we're going to move on to our next speaker as well, unless we have any more questions. But one question is, do you still recommend wearing PPEs when this device is approved?
Yeah, that's a great question. You know, I think for the safety of a company, we would say, yes, you should wear PPE also. And I think the idea is that this will dramatically decrease aerosolization so that if your PPE were to fail, you would be okay. In my heart of hearts, do I think you also need full PPE? I would say maybe not, but I would never make a recommendation like that publicly.
Thank you, Ted. Everybody knows. I was just gonna say, Ted has been an amazing team player. He did mention in his talk how he's come to this mission with his children, and he's inspired so many people. A lot of people have learned so much. I have learned from him in our trips that we have taken together and operated. This is the only foundation where you get to have people like myself, Ted, Mike, George, you know, coming with Lisa and April operating together, and patients around the world. And I always tell people, I couldn't afford, you know, if I was in other parts of the world, to pay Dr. Schwartz to come and operate. No one could afford it, because at the end of the day, you know, his services are so specialized. So he does it from the kindness of his heart. And we're very grateful to you, Ted, and your family, your children. And we look forward to many, many more years. 2021, we go live again.
Sounds good. Dr. Q, it's been a pleasure. April, been a pleasure coming on all the missions. And I really missed it this year. We were so looking forward to it and so disappointed we couldn't go, because it's so meaningful, so special, and something I really enjoyed. So thank you, Mission Brain, for the opportunity.
Thank you so much. We can't thank you enough. And yes, looking forward to 2021. And please stay healthy and well to you and your family and everyone in your team. Thank you so much.
Thank you.
So our next speaker is Dr. Gerardo Legaspi, and he is the Director and Chief of Neurosurgery at the University of the Philippines, Philippine General Hospital. And he is going to talk about the neurosurgical training and service at PGH during the pandemic.
Good morning, everyone. It is my distinct pleasure and honor to be part of this webinar sponsored by Mission Brain regarding the effects of COVID-19 pandemic on our different neurosurgical services. Next slide, please. The Philippine General Hospital is located in Metro Manila in a 24-acre facility with 1,500 beds that service around 700,000 patients a year. Half of these patients come from outside of the city, and there are 4,500 employees that serve these patients, as well as train around 4,700 individuals under the academic programs of the University of the Philippines. We do around 2,000 neurosurgical operations per year in PGH. Next slide. It has seen its own share of disasters and calamities in the past. Next slide. Including World War II, where it was completely bombed out. Of course, next slide. It is now in the middle of another one, this COVID pandemic. And for us, March 16 was when the lockdown was affected for the whole country. Next slide. When this was announced, we had to close off the hospital to all elective admissions and semi-urgent consultations, limiting cases to urgent and imminent ones, and life-threatening conditions as well. Hence, our very busy emergency room, next slide, became empty for us to be able to accept the COVID positive patients that were referred to us from half of the metropolis. Okay, next slide. We had to also convert our internal medicine ward into a COVID-ready facility. Next slide. Having changed the ventilation because negative pressure cannot be achieved in these very old wards, allowing us to ensure adequate air exchange for our patients and our health workers to be safe within. So next slide. After all of these changes, we were ready, and on next slide, please. On March 30, we opened the Philippine General Hospital formally as a COVID-19 referral center. Next slide, please. This has brought a lot of changes in our services. It also as well affected training and research, of course. We were able to share this in a letter to the editor in the World Neurosurgery, where we mentioned, next slide please, that we had to employ perioperative precautions to further limit the risk of transmitting this disease. By that time, we didn't know who had it because there was no testing readily available in our hospital early on. So we kept the number of people in the operating room to a minimum, who were mandated to have a huddle before the operation to discuss the procedures and rehash the safety protocols. We even decreased it even more during intubation and extubation, and use aerosol boxes at the start, and all of them with video laryngoscopic intubation. Slide, please. The dictum that we took was that anyone who went to the operating room was potentially contaminated, patient and staff alike. So at the start, everyone was in a level 4 PPE. We were not allowed to bring in our phones and personal belongings, and supplies were carefully handed to the personnel from anterooms. Slide, please. The strategies that we employed to reduce infection further was to reduce operating time and incorporate all of this into the surgical decision making. So we employed smaller craniotomies to have less blood loss and less operating time. In fact, in some of our urgent pituitary adenoma cases, we favored the craniotomies rather than the aerosol producing transsphenoidal approach. Slide, please. The knowledge, the technique developed with the keyhole surgery and microtherianal craniotomies came in very handy, which allowed us to do the surgeries at a shorter time, and of course opening the frontal sinus, hence producing more aerosol in the air. Slide, please. To decrease further the exposure to aerosols, we employed the use of sterile transparent plastic sheets, and the residents use this. We use this especially during bone work, where drilling and cutting of bone and dust production as a result of that happens. Slide, please. The anesthesiologists further closed off orifices of the patient's face with water impermeable occlusive dressing sealed around the endotracheal tube. Slide, please. As part of our contribution to the dwindling human resource because of infection or the increased demand of COVID patients for personnel, neurosurgical residents were tasked to share the responsibility of manning the ICUs in a task sharing model, and I think the internal medicine staff favored neurosurgical residents because of their wide knowledge in ICU care, which is part of their training in our program. Slide, please. Of course, the teaching had to continue despite all of this, and although we had to employ online techniques for this, our consultants still came for the surgeries when the residents needed them to be in the operating room. Otherwise, the the weekly conferences that we have are all via Zoom meetings. Slide, please. All of this led to a decreased operating opportunity for our residents, most specifically our junior residents, because we had to plan the cases to ensure that our two graduating senior residents had the adequate cases for them to be qualified for graduation. So cases were selected to satisfy this requirement. And of course, even the simpler tumors or cases that could be done by more junior residents were given to the more capable team members, most especially the seniors, so that you reduce overtime, morbidity, and mortalities. Consultants were also requested to scrub in most cases, so that we decrease the turnaround time in the wards, reducing the need, increasing the utilization of our reduced bed capacity. Slide, please. I think one of the good outcome, or I may call it the silver lining of this pandemic, is that our research output has never been more productive than this year. In the past few years, we'll be fortunate to have produced, our residents to have produced 2 to 3 publications in the year. But for now, for this year, in the last 10 months, we have managed to publish around 16 papers already. And I think there are even more lined up for publication. So I think the extra time that we have because of decreased operative load was put to good use by our residents. Next slide. The other challenge aside from training is the rendering of service, because we all know that the decreased mobility of patients, and they had no means to get to our hospital, coupled with the fact that in the country the ratio neurosurgeon to patient ratio is almost 1 to 1 million. So there's a very small opportunity for our patients needing neurosurgical care to access this when it is most needed. So as director of the hospital on June 1, we started the gradual resumption of our elective and urgent, semi-urgent cases using a prioritization scheme. Next slide. In preparation for that, we went to our outpatient lists and discovered that of the backlogs that we have for brain tumor, 11.5% of those that we were able to contact have already passed away because of the disease. So this is a clear example of what delayed intervention or service can lead to in a pandemic like this. Next slide. So when we started resuming our elective surgeries and comparing it to last year, we realized that from March 15 to June 30, our cases were only 9% of what we used to have in the previous year. So this is a marked decrease in our operative load and our ability to serve our countrymen. Slide, please. As far as emergency surgeries are concerned, I think being able to do around 70% of them from previous months, the previous year, still a good batting average, but still we have the 30% who were deprived of care, neurosurgical care. Next slide. Just to give you a summary of how the numbers have evolved through time, through the months of this pandemic, having peaked in our cases in January, we saw a gradual decrease until the lowest, the ebb of the tide, so to speak, in the early April, late March and early April, and started to pick up when we opened the hospital again in June. And now I think we're going in a steady state, waiting for a surge or not to happen, so that we can increase further our caseloads. Slide, please. So to help us rationalize this process, we put together a surgical review committee wherein all surgical cases were bundled together, and the consultants and residents conferred with each other as to which case to bring in based on the uh, urgency of the case, having been determined as agreed upon based on protocols. So malignancy went ahead of the non-malignant ones. Of course, the more urgent ones had to go ahead. And we also advised those cases needing ICU care to be deferred temporarily, since ICU was not available because the beds were all occupied by COVID-19 patients. Slide, please. So this is a slide that I'd like to take a few minutes of your time to show you that the yellow line, the orange line, which is our tumor load, started to decrease as March approached, as we opened as a COVID referral center, and started to increase when we opened. I think the urgency of tumor cases allowed us to bring them to the OR easier than the other cases, compared to the blue graph that shows the pediatric patients decreasing significantly and not being able to recover, as well as the tumor cases. Our trauma cases, those in yellow, remain low because of the decreased mobility because of transportation limitation within the city. Next slide. So our other experience that I'd like to share is that our COVID-19 patients, COVID positive patients, fared very poorly, having a high mortality rate, proving the fact that COVID positive patients fare with a worse prognosis than those that are not positive. Next slide. As we go through the numbers and through the months of our general admissions, we see a gradual increase in our ability to admit patients into the hospital, and thankfully this is reflected as an increasing number in our surgeries as well. And as we proceed to resume our activities, next slide, we are faced with the challenge of maintaining safety for our patients and our healthcare workers. Fortunately, now we have a testing capability that allows us to have turnaround results in 2 to 3 hours, coming very handy for especially for the urgent cases. What is really different now is the large volume of PPEs needed to run this big hospital, giving us an additional burden of around $1 million a month to procure these PPEs for our personnel. Slide, please. And also in resuming our outpatient services, we are constrained by the fact that internet is still unstable in a lot of parts of the country, so that our online telehealth consultations, which comprise a big bulk of our outpatient services, can be hampered by it. So we are happy to note, though, that face-to-face consultations have been increasing steadily since June 1 of 2020. Next slide. So having shared with you all of this, I think we have come down to the fact that this pandemic has severely affected our ability to serve our neurosurgical patients, and we have to start, so to speak, shaking off from the COVIDification of our healthcare. So exactly that's what we're doing now. I'm now steering the hospital to opening more beds for the non-COVID patients, and since the numbers are starting to go down as well, we are grabbing this opportunity to do this. So again, I hope we have given you a good an idea on how COVID has played its role in our hospital and our neurosurgical service and our ability to give it to our patients. And I share with you the optimism that in the near future this problem will be solved. And we go back, next slide, to how we were before, sharing knowledge. Next slide. With Dr. Michael Lawton visiting us since 2014. Next slide. Showing us his skills in aneurysm and AV malformations and other vascular diseases. Next slide. Followed by the arrival of Dr. Mitch Berger, whom we have had every year since 2015 also. Next slide. And the Mission Brain team fulfilling their promise of coming regularly to teach us and share their experience with us. So next slide. We hope to see them again, to see all of you again when the circumstances allow it. Next slide. Thank you very much, and good morning to everyone. Next slide.
Thank you very much, Gap. That was a very interesting and informative presentation. Dr. Quiñones, would you like to say a few words? Do you have any questions before I take any of the other questions?
Beautiful. No, both some comments, of course, and then some potential points to discuss. You know, Gab, this is an amazing amount of work. I saw all the cases that were happening. I think that what a lot of people didn't realize, and what you illustrated right here in your presentation, is that despite of everything that was going on around the world, shutting down and so many things, there were people like you and your team as the unsung heroes in the background, continuing to take care of patients that during the pandemic, and because the disease didn't end, you know, brain tumors, vascular lesions, spine disorders did not end. They continue, and patients continue to be affected by this problem. So when you look at your data right here, Gap, in a beautiful way illustrated, what are the things that as you look back, you know, in the Philippines, you wish you had known maybe around March, April, May? And the second part of that question is, what are the resources that you think could help you and your team be able to deliver more efficient care for your patients?
Well, I think the everything that we know now in retrospect is that the fear of the virus at the start was really probably not as should be as much as we have expressed it in the start. So the fear of the virus is the one that paralyzed us, and knowing now that maybe we could have been more open to the other cases rather than close off. No, we are a 1,500 bed hospital. We closed off 1,100 beds to serve 400 patients because we didn't want infection in the hospital. And this is probably one thing that, if in retrospect, if we knew that, you know, with regular PP, with the proper protection, we could have continued the operations without much fear of infection, then I think that would have helped sustain also the numbers for our patients and the service. In terms of equipment, I think it's really, as shown by Dr. Schwartz, it's really the ability to decrease further the infection probability. Negative chamber, we don't have a negative pressure room in the whole hospital. So yeah, we're building a few now. But I think the proper infection control, which we are starting just to roll out now, would have come in really handy for us to be able to serve more patients.
Beautiful, Gapti. So we have a few questions right here. If it's okay with you, I'm going to work with April back and forth. There was one question about one of the attendees is, during this time, at least in the Philippines, let's focus in the Philippines, and then I can comment here in the United States, I listen to our program. The question is, how many doctors apply for training in neurosurgery this year? And did that number of trainees has decreased secondary to COVID. And I just want to put it in perspective. You said something very, very remarkable. Your hospital is a 1,400 bed hospital. Just to put it in perspective, our hospital here in Mayo Clinic in Florida is only 300. So your hospital is 5 times. These are massive hospitals that serve millions and millions of population, you know, and that goes back to training. So that question is, did you see a decrease? You know, and the second part of that question is, where the senior residents and the chief residents that you have now are able to graduate with enough cases?
Yes. Okay. There is quite a change that happened this year. So the number of residents applying is not really truly reflective of the situation. Because of the pandemic, the yearly board exams for graduate doctors who have just graduated, the licensure exam was postponed. So we have to wait for that exam in November to see how many will apply exactly. But as of now, we have reached already more than 2/3 of those that usually apply for the year. I am projecting that after the licensure exam, we will have more applicants this year than in the previous year put together. So I'm happy to announce that our residents are going to graduate this year. They are looking forward to having their fellowships after graduation, and I think as director also of the hospital, I tasked our departments to make sure that we start programs for the different surgical departments, especially to help our graduates from the different surgical departments graduate too. So this is a hospital-wide push that we're doing now.
It's interesting for us, at least here in the United States, what we're seeing in some of the programs gap is a rise in applications, as a lot of them are electronic nowadays. Number one. Number two, the interviews are all going to be conducted via Zoom, electronic sort of connections, virtual interviews. Number three, even our oral boards for the American Board of Neurological Surgeons are going to be conducted also through virtual connections, because of course, their overall recommendations, at least in some of our healthcare, for instance, here at the Mayo Clinic, is we try to restrict, you know, gatherings to 10 people or less, and that's difficult to do in so many venues, obviously, especially for training and for testing. There was one question as to whether or not there are any other learning adjuncts that you utilize for your residents during this pandemic that would be worthwhile for other people around the world to know.
I think we have started concentrating on some of our outside the operating room activities, such as simulation. This has given us an opportunity to start our microanastomosis lab, which you actually set up in the office, so that residents can do their practice anytime. So I think this pandemic has brought forth for especially an institution like us, the need for simulation activities, surgical simulation training that will keep our residents busy even without actual patients on hand. So we are now redirecting our resources to getting those facilities for our hospital.
Great, thank you very much. Oh, sorry, Dr. Quiñones. Would you like to say anything else?
No, I was just gonna say, April, that the landscape, of course, of training is changing, and I think that the way that GAP is doing it in the Philippines, the way that other people around the world, we can definitely learn from each other and build bridges, so that way our trainees continue to get state-of-the-art training, you know, as they take care of patients.
So I have one more comment here. It's not a question, but I think it's a comment from probably one of your colleagues in the Philippines. And they would just like to thank Dr. Legaspi for the lecture. It was very eye-opening and can serve as a guide to their practice in the provinces, and thanking the organization as well for this initiative. And I'm glad that everyone's really getting a lot of learning from this discussion right now. So as to tie it all up, Dr. Legaspi, thanks again for joining us. I know it's very late at night there in the Philippines. Very great presentation, and stay safe and healthy to you, your family, and all your team over there in the Philippines. So we're gonna move. Thank you. We're gonna move forward to our next speaker. Our next speaker is Dr. Carla Venegas Borsellino of Florida. She's Assistant Professor of Medicine and Consultant of Critical Care at the Critical Care and Neurocritical Care Departments at Mayo Clinic in Florida. Dr. Venegas, welcome to the panel today.
Good morning. How are you doing? It's a pleasure to be here. Thank you for the invitation, Dr. Quiñones. And it's the first time participating in Mission Brain, and it's a pleasure to be here.
Welcome, Carla. We're delighted to have you, and we're looking forward to your presentation. It's a great honor. You're probably around the corner in the unit right now, so that's good.
Good morning. My name is Carla Venegas Borsellino. I'm a neurointensivist at the Mayo Clinic in Florida, and I want to thank the organization for the opportunity to participate in Mission Brain Live Symposium 2020 and talk about this important topic of connecting and community building in a time of social distancing and social disruptions. I want to talk about the neurological implications of the infection and share the experience at the Mayo Clinic. So even though COVID-19 or the severe acute respiratory syndrome coronavirus 2 mainly affects the respiratory system, neurological manifestations have been described in a good number of studies. Actually, this is not surprising, as the neuroinvasive effects of coronavirus had already been described during the 2002 SARS outbreak and the 2009 MERS outbreak. Today, more than 9 months into the battle against COVID-19, doctors and scientists have gained a better understanding of the disease and its symptoms, and we have more information about better ways to treat the disease. However, there are still many things to discover, such as the mechanism by which COVID-19 causes some neurological symptoms and the implications within our community. We recognize that this pandemic has brought many social challenges, and sadly, we all have been affected in some way at the personal, family, or professional level. We know that the healthcare systems, food, and other supplies change, as well as the economies of all, if not all, countries have been affected in a significant way. In the next few minutes, I would like to talk about the impact of COVID-19 on the neurological system and comment on how the Mayo Clinic in Florida has adapted to this new reality that caused global disruptions and required dramatic adaptations like social distancing, mask wearing, lockdown, and so forth. So today we have more information on how the virus affects the nervous system and how it manifests itself at multiple levels, from encephalopathy to stroke or even something more subtle like delirium. While neurological complications appear to be more common in severe COVID-19 cases and also appear to be more common in older patients who have pre-existing risk factors, we still do not fully understand the process in the development of these neurological disorders. When we talk about the neurological involvement in COVID, we refer to 3 different situations. Firstly, neurological manifestations of a viral infection. Secondly, post-infective neurological complications. And thirdly, infection in patients with neurological comorbidities. The neurological manifestations of a viral infection include symptoms that reflect the direct effect of the virus on the central or peripheral nervous system. Central nervous system symptoms include headache, dizziness, delirium, encephalitis, stroke, and seizures. Now we know, for example, that headache in COVID-19 is usually associated with fever, and it has been reported in about 6 to 13% of COVID-19 cases. Headache is reported in both old and young patients. On the other hand, delirium or altered mental status, including agitation and confusion, has been documented in more than 1/3 of COVID-19 cases, and it is more commonly found in elderly populations. It can be related to underlying reasons, which include viral encephalitis, metabolic disbalance, toxic or infectious encephalopathy, post-ictal seizures, and stroke. Now, talking about stroke and cerebrovascular events, they have been reported in 6% of the cases showing neurological symptoms. 5% are related to acute ischemic stroke, 0.5% to cerebral venous sinus thrombosis, and the other 0.5% related to hemorrhagic stroke. Therefore, thrombotic events are much more frequent than hemorrhagic events. Patients with strokes are significantly older and more likely to have pre-existing vascular risk factors. The mortality rate is higher in COVID-19 stroke patients, indicating a worse prognosis in this group of patients. The peripheral nervous system manifestations mainly refer to skeletal muscle injury and peripheral nerve involvement. And by now, I think we are all familiar with the presence of hyposmia or lack of smell, hypogeusia or lack of taste, and neuralgia associated with COVID-19 infection. While some patients with COVID-19 are experiencing slight smell or taste loss for a short period of time, others may lose their sense for weeks. So the severity of the clinical impact clearly varies, and I don't think we completely understand the clinical impact of this symptom. Now, the second type of neurological involvements are the post-infective neurological complications, which include demyelinating conditions which had been documented previously following coronavirus infection. There are reports of cases of Guillain-Barré syndrome which have shown a latency period of 5 to 10 days before the onset of neurological symptoms. The diagnosis of Guillain-Barré syndrome can be suspected in a sudden, poorly explained worsening of a patient's respiratory status once the diagnosis of COVID-19 has been established. There are also reports of cases of acute myelitis in patients known to have COVID-19, possibly affecting the cervical spinal cord. In these cases, antiviral therapy along with immune suppressive therapy has been reported to improve viral weakness. Additionally, a topic that is very important for the critical care unit, since about 10% of hospitalized patients require ICU care, healthcare providers must consider the possible development of critical illness neuromyopathy, a complication known to delay weaning from the ventilator and significantly increase morbidity and mortality. Okay, the last category of neurological involvement occurs in patients with prior neurological comorbidities like dementia, reduced mobility, or need for immune suppressive therapy, which may predispose a patient of developing a viral infection. We anticipate that patients with neurological comorbidities may face special challenges during this period of social distancing and home isolation, especially if they need assistance for daily life activities. So regarding the cause of these neurological problems with COVID-19, they seem to be related to hypoxic ischemic injury to the brain, but other mechanisms may be at play, including direct viral invasion of the nervous system and an autoimmune response directed against the brain, spinal cord, or peripheral nerves that is triggered by the viral infection. Currently, there are a variety of research efforts at Mayo Clinic to uncover the neurological implications of the disease, including stroke and neuroinflammation. So nowadays, we understand that the severe complications of COVID-19 are not only related to an uncontrolled infection by the virus, but are also related to our own immune response to the virus. Therefore, researchers are trying to identify immune system markers that may predict who's at a particular risk of those serious implications. So in response to the need for social distancing and avoiding congestion in healthcare facilities, the CDC and the Center for Medicare and Medicaid Services in the United States are prioritizing urgent and emergent visits and procedures, recommend postponing any outpatient procedure unless it is urgent, reducing ER visits if possible, and minimizing face-to-face contact. So to maintain appropriate levels of medical care while protecting our patients and healthcare providers, telemedicine at Mayo Clinic is becoming mainstream in outpatient and some inpatient management. The pandemic has forced healthcare personnel to all specialties really to adapt to a new clinical reality. And even though telemedicine has been practiced for over a decade in the United States, and for a good amount of time at the Mayo Clinic, its use has been now accelerated. As compared to in-person care, telemedicine appears to be cost-effective, and many reports have demonstrated non-inferiority in the treatment of neurological disorders. Patients perceive it to be cost-effective and convenient. So yet the implementation of teleneurology is challenged by laws and regulations at the state and federal levels in the United States. Still, the implementation of telemedicine reduces healthcare costs and provides an economic benefit to ensure sustainability of practices at institutions of different sizes. It has a considerable impact on public health and delivery of care, especially in low resources settings. Therefore, we believe that neurologists should support the continuation of this trend in practice. Telemedicine should no longer be considered as the last resort in time of crisis, but as an essential tool in practicing clinical neurology and we consider it a necessary skill during the current COVID-19 pandemic. This practice prevents infection by supporting social distancing, avoiding close contact, while providing a high quality care to our patients. Thank you so much, and we are open for questions.
Thank you so much, Dr. Venegas. That was really interesting. We have one question here already. And it says, si tomo antidepresivos afectan las secuelas neurológicas.
Las secuelas neurológicas. Now, do you want me to answer in English or in Spanish?
Probably be better. Yeah, probably use a universal language. So they wonder whether or not, Carla, is if they are, when antidepressants would have any sequela with any of these issues with COVID.
Yes. So again, thank you so much for the invitation. I'm in the critical care unit, and I have seen a big volume of patients from taking care from the respiratory failures, multi-organ failure, and I have seen the impact of the disease in the neurological system. We really see the patients with weakness. We see them with delirium. We see them with brain bleeds, etc. So I think the pandemic has bring us a lot of challenges. Some of them are literature changes every day. Every time that we are doing a talk, you have to check the last 1 or 2 weeks data because we are having changing numbers. I think another difficult thing is we have literature that some of them are published in peer-reviewed studies, but some of them are just online, open access, not all full review studies, and a lot of the data that we get is from that. And the other challenge is we don't have enough length of long consequences or stuff like that. So I don't think we have a lot of data about how the antidepressants are changing this disease. I know we are using in the ICU in a good amount of patients. More than antidepressant, we use antipsychotics like Seroquel, like Quetiapine. We have to use sometimes Haldol and Prexadex, the dexamethasone, because we do have patients with a lot of delirium, depression, just weakness that is beyond what we usually see in the ICU. So more than a side effect from those medications in the COVID patients, we're really in the need of using them to keep our patients engaged. So remember that during this pandemic, we're doing a lot of separation. Our patients, especially our COVID patients, they have no visitors. All their meetings with their families are through Zoom devices. We as healthcare providers try to limit our time inside of the room of the patients. So the sense of isolation is huge, and the sadness, the lack of hope is significant. And we are using more and more medications to decrease depression, anxiety, delirium, to help them to go through this crisis.
It's interesting, Carla, Dr. Venegas, that you mentioned something, because we're seeing a tremendous need and crisis in the United States alone for mental health during this pandemic, because of social isolation, because, as you said, we don't understand exactly how even the disease itself is affecting the neurological system. And then on top of that, all the pressures that come along with all the way from social, economic, being disconnected, a lot of these things. So they're very related. There's another question that is got some sort of relation to this, and especially for COVID-19. So this is from Nina Flores. And this is actually a question that made me reflect on this. Just curious, Nina says, was there any previous evidence, data, study of the neurological complications from H1N1 or MERS? These are obviously pandemics that have affected. So what do you know about what these other things have done to the neurological symptom? And then maybe, what do we know about what this particular COVID-19 is doing to our neurological symptom as a comparison?
Yes, there is a good data, and I know that the first few months of the pandemic, February to I'm sure around April, most of the guidelines that we got to how to manage patients, what to do, what kind of medications to use, hydrochloroquine, remdesivir, HIV medications, etc., came from data that we have from SARS-1 and from MERS. And we do have evidence that in different proportion, both viruses affect the nervous system. So yeah, as I mentioned, there are three major mechanisms, and most likely the most common is the hypoxia induced by the severe respiratory failure, the hypoperfusion that is causing the brain damage. But there is evidence of some invasive mechanism. And I say, the very good data now about the atrophy that we can see in some nerves, especially the olfactory nerves. And that's why we're having all this lack of smell on this patient that lasts a good amount of time, up to like a month or 2 months after the infection. We have a data from the prior viruses from MERS and SARS of affecting the receptors, the H2 receptors, and the myelitis. There are reports of necrotizing encephalitis. So I think that's information that we knew that could happen, and we are confirming, we're seeing it. There are reports coming from all over the world, more and more about these effects. I think they are a little bit out of what we, as general community, think about. We think about the respiratory failure, we think about the clots, the PE, DVT, but the neurological symptoms are significant. But some of them, just like the fatigue and the headache, just everybody kind of like pass them and go to work with them, etc. But I think they are significant.
And we're beginning to see, Carla, for instance, I'm beginning to see patients who were positive for COVID, and suddenly they have a neurological situation for which they get an MRI, and they find these lesions in their brain, i.e. tumors, and they're asking me, do you think that this tumor could have come up from this virus? And the answer is, we don't know for sure. I mean, we are so early on the stages, but we know that we had brain tumors prior to this virus. So it's unlikely related, but these are legitimate questions. Just so you know, Carla, we have people all the way from Russia, Europe, Central and South America. The only continent that we don't have represented, at least for what I can see right here, is Africa. But we may have some people from Egypt. I'm going to double check. But we have people from all over right here looking at this. April, what other questions do we have?
Yes, we have one more question, and I think we're going to move on. And this is from Ali at Radmanesh. Ali Radmanesh from NYU. He's a neuroradiologist, and he said that they saw many cases of diffuse leukoencephalopathy in critically ill COVID-19 patients, which later evolved into cystic areas within the parenchyma. Have you had a similar observation in Florida?
Yeah. So I know what that report you're referring to. Again, when I have not seen them, I have not seen these patients, but I think it's different limitations. One, as I mentioned, some of the reports are, again, all peer-reviewed reports. Not all of them are peer-reviewed reports. So even for this study, I understand there is some concerns of if there is a clear relationship between the development of the SARS-CoV-2 and the brain lesions. But the other limitation that we have is we really are not sending our patients for MRIs that often. So they have some neurological changes, and many times that's what I see every day in my practice. They are so hypoxic, they are so unstable in few pressor, CRRT moving, that we really think 3 times before sending them for a CT scan. If the neuro exam is just some confusion, delirium, but not necessarily a focal deficit, and more or less often MRIs of the brain. So I think that I'm sure you were missing some of the diagnosis, we're under-reporting diseases because we are just not sending the patients for those studies. For, again, logistics, patients are unstable, and then we have to contaminate an MRI suite and then do the total decontamination after.
Very, very good point. Maybe I link the last one, April, if you don't mind, because this one is just related, and Carla can answer pretty quickly. And Isabel Martin Monzon was asking whether or not there are any data available about the neuropsychological deficits following, COVID-19 in our patients, in your patient population, for instance, here at the Mayo Clinic.
We are seeing them. I have to tell you that my patients, once they recover from their respiratory failure and they recover from the shock and they are already going over the ICU complications, while we are keeping them for a longer period of time in the ICU, the psychological complications, psychosis. I have patients who see stuff, they have delirium, and we usually deal with ICU delirium, but it's kind of beyond what we usually see. They are confused, they talk crazy stuff, and we just have them for a month in the ICU, still attached to dexamethasone, Seroquel. They are frying from their respiratory status. So it's not a patient that you just can send him somewhere else and take care of the psychological effects. We are sending them. And I think as outpatient, what I understand from the outpatient clinic is this is one of the major concerns and complaints that I don't feel the same. I'm just not feeling the same motivation I had before the pandemic. I'm just not baseline. I just want to go to sleep the whole day, etc. So we are seeing it, and I think it's again underreported.
Thank you. I do have a quick question from myself. What percentage are you seeing of these neuropsychological issues with these patients?
So it depends on the reports, and they varies according to what they count. And again, if you count all neuro side effects containing even headaches and delirium, etc., the reports are as high as 70%, 75% of patients can have any of those, again, fatigue, headache, delirium. Now, when they put them in the most complex one, like a stroke, we know it's about maybe a 5 or 6%. The Guillain-Barré is a very significant amount of patients. Again, there are reports of 19 patients here, 8 patients there. Everybody has seen at least some good reports of Guillain-Barré. So it depends what pathology you are talking about, but if you put them all together, again, we talk about 75% of patients, maybe around 40% have delirium and ICU delirium.
That's a huge number. Well, Thank you so much. That has been very interesting and very informative. We really appreciate it. And I'm sure a lot of our audience have a lot more questions and have all these thoughts going through their minds, but we're going to keep going here. Thank you again, Dr. Carla. Have a great day and stay safe and healthy. All right, our next speaker is Dr. Dong Trong Kin from Hanoi. He has been in the Department of Neurosurgery at St. Paul Hospital for 17 years with an interest in skull-base and cerebrovascular surgery.
Good evening, good afternoon, ladies and gentlemen. I'm Dong Trong Kin, a Vietnamese neurosurgeon from St. Paul Hospital in Hanoi. Thank you for the kindly invitation from Mission Brain Foundation. I'm very honored to be here for sharing our experience in prevention of COVID-19, one of the most terrible diseases in the human history. Next slide. Vietnam, located in Southeast Asia with a population of over 97 million at the moment of September 2020. The capital of Vietnam is Hanoi, located in the north, but the biggest city belongs Ho Chi Minh City in the south of Vietnam. Vietnamese is the official language. Other popular languages include American, French, Russian, and China. Next slide. The COVID-19 in Vietnam began on 23 January. The first 2 cases of COVID-19 in Chợ Rẫy Hospital, Ho Chi Minh City were reported. It marked the first period of this disease in Vietnam. On 11 February in Sơn Lôi, a village that far from 15 km from Hanoi were isolated due to the increase in the number of the patients. But after 20 days without new case, Sơn Lôi were approved to remove quarantine. Next slide. The second wave in Vietnam began on 6 March 2020 when Hanoi announced the first case. The patient was 26 years old female. She had been traveling abroad during the outbreak. She also the 17th patient in Vietnam. After that, the number of cases increased so quickly that on the 1st April, Vietnam applied social distancing nationwide for 15 days and announced the nationwide outbreak of COVID-19. Next. During the isolation time, the normal activity were limited. Only the market, hospital, and pharmacy had opening permission. The Vietnamese government did not allow to gather over 3 persons. Mask protection must be used in the public. All the conference, festival, even wedding ceremony must be delayed or cancelled. Next slide. At the second wave in Vietnam, the most dangerous hotspot was Bạch Mai Hospital. 2 nurses in Bạch Mai Hospital and some employees of a food supply company for this hospital got positive without any contact with the COVID patient. That is the reason why the president of Hanoi decided closing this hospital to prevent the spreading of the disease. A few hospitals were established inside Bạch Mai for preparing the storm of the COVID-19. Next slide. On 26 March, the patient number 175 visited his son who was treated at the orthopedic department of St. Paul Hospital. After his positive test confirmed, the board of directors of St. Paul Hospital decided to isolate the orthopedic department to screening all the staff, patients, and their village. That was the hardest moment of my hospital in the pandemic. The isolation lasted only 2 days after all staff were confirmed negative by CDC Hanoi. Next, the Vietnamese government and Ministry of Health decided the National Hospital for Tropical Disease became the Hospital for Management of COVID-19 in Hanoi. A national network of telemedicine also created to discuss the severe patient not only in Hanoi but also in the other cities. The drastic epidemic control measure had positive results, and the country did not confirm any cases of local transmission from April to the end of July, and the country already started to open up. Next slide. From 15 May to 21 July, Vietnam passed over 19 days without new COVID from local transmission. All new cases in this period were people who had been infected abroad and who had been placed in the government quarantine facility after arriving in Vietnam. According to Vietnam rule in the pandemic, all the people who enter to Vietnam must be required to submit a health declaration, undergo COVID-19 medical check upon arrival, be isolated during 14 days, and got 3 times negative with PCR test before returning to normal life. Only 3 of 22 airports have a working permission for the return flight of Vietnamese people who work abroad. Next slide. In despite of the strong effort, the third outbreak of COVID-19 started in Da Nang City on 22 July. C Hospital became the hotspot when the patient arrived at the hospital due to the coughing, feeling tired. After diagnosing him pneumonia, his sample had positive test with COVID-19. Few days later, some doctors and nurses of the other department in C Hospital got positive test. Da Nang was locked down 3 days later, and a temporary 2,000-bed field hospital was created for the emergency situation of the city. Da Nang is one of the most popular touristic cities in Vietnam. Many people from other cities of Vietnam arrived here for traveling before the third outbreak happened. That is the reason why the Vietnamese government asked the other cities of Vietnam increase the level of the alert, and authorities began mass testing around the country for the people coming from Da Nang in July. The first death was a patient who was treated heart failure and diabetes in ICU of C Hospital. He was the 426 COVID-19 patient in Vietnam. Next slide. The Ministry of Health has issued Vietnamese and English guidelines as a propaganda measure against the novel coronavirus. See publication help everyone to understand exactly how to self-protection against the disease. Next slide. Here is a principal milestone of COVID-19 in Vietnam. You can see the first, the second, and the third wave, some important time during the pandemic from January to September 2020. Next slide. Now you can see the detail of the coronavirus pandemic in Vietnam. Totally, we have 1,074 cases in comparison with over 13.3 million in the world. 13.5 deaths were confirmed by COVID-19 in my country, and 999 patients were treated successfully. Our mortality rate is about 3.2% and equal as the mortality rate of the world. We have over 50,000 persons are under quarantine. Next slide. St. Paul Hospital is the last multi-field medical complex in Hanoi. It was founded in about 1902 during the French colonial rule in Indochina. It used to be a cathedral combined the treatment and take care of the French soldiers in the war. After the war, it became to the public hospital for the Hanoi people and the other provinces around the capital. Now, St. Paul has over 500 beds with 1,100 medical staff, 56 departments. In the year of 2020, this is the 15th anniversary of my hospital. Next slide. From the beginning of the pandemic, St. Paul Hospital applied a lot of rigid methods in preventing this disease. The patient will be required to submit health declaration before entering the hospital. We apply the e-declaration that connect to the other hospital system to follow the patient medical history. The patient will answer the question about the symptoms such as fever, coughing, and history of traveling within 14 days. If the patient is suspected, they will move to a different building for screening. If they test positive, they will transfer to the National Hospital Tropical Disease. The hospital asks the patient and their family to pay seriously the recommendations inside the hospital, such as wear the mask, keep the distance with the other, only one member of family visits the patient every day. We also established one-way hospital. That means the entry and exit gate are different ones. All the medical staff are required not to travel the city of pandemic, use different self-protection during the working time. For example, wear mask protection, wash the hand many times, and self-isolation in case of having symptoms like cough, fever. Until now, we have just only one case. This is the patient number 175 in Vietnam. No doctor, no medical staff, no nurses in St. Paul Hospital have positive tests with COVID-19. Next slide. Vietnam's success has drawn international attention for its early proactive, transparent, whole of political system and whole of society action led by the government. With the support of the World Health Organization and the other, we have been preparing and improving its health system, especially to prevent, prepare for, detect, and respond to the public health emergency as part of its long-term investment plan. The country was building on lessons learned from period outbreak in good SARS in 2003, which it also handled with remarkable success. From the first two cases, the government started to put a precautionary measure into effect by strengthening entry screening measure and extending the state holiday for school. Vietnam developed its protocol quarantine and isolation policy to control COVID-19. As the next wave began in early March, the government knew that it was crucial to contain virus transmission as fast as possible in order to safeguard its economy. Vietnam also closed its border and suspended international flights from the mainland China in February, extending it to UK, Europe, US, and the rest of the world progressively in March. In our opinion, prevention is always the best. Next. Other innovative methods were also used to keep the public informed and safe. For instance, regular push messages with Ministry of Health update on preventive measures and the symptoms of COVID-19 was sent through a mobile service provider. A song was released with lyrics raising public awareness on COVID-19 and hand washing. With effort from both government and the public, Vietnam was able to control the earlier wave of the COVID-19 outbreak in the country and following many of the same strategies, with hopefully control the current wave errors. Next slide. An application on Google Play and Apple Store named Blue Zone was developed by Vietnam Ministry of Information and Communication and Ministry of Health under the direction of the Prime Minister. Blue Zone shall alert if you have close contact with people who have COVID-19, thereby minimizing the spread of the virus to the community. When there is new case, you can learn whether you have close contact with the case or not simply by assessing Bluezone. The more people install Bluezone, the more effective it is. Next slide. This application is recommended to install for everyone. I have just presented the way of Vietnam and Saigon Hospital to prevent and manage the COVID-19. Saigon Hospital make a good relationship with the hospital from the other country. Before the COVID occurred, the international medical staff usually visit and perform surgery in my hospital, and Saigon doctor and nurse are sent to the hospital for studying. In neurosurgical subject, the neurosurgeon from US, France, Korea, and Japan visited our department and have us treat aneurysm, IVM, brain tumor, and spine. Due to the COVID-19, this program is postponed in 2020. I hope that in the near future, 2028, the foundation Missing Brain will visit our hospital and department to help my team and my Vietnamese patient in neurosurgical disease. Thank you so much.
Beautiful remarks, Trung, beautiful remarks. And just so people know, as we put it in perspective, as I see Will right here, April, and we're looking into, Dr. Kine, he reached out to us this year, asking us to consider coming to Vietnam to do a mission. And as you know, we have limited resources and we travel to many countries around the world. And this is one of those countries that we wanted to learn more about what they're doing and how they are taking care of patients, so that way we can potentially put it as one of our wish list and convince our board to make sure that they allow us to go and participate in one way or another to help. So a few questions right here that April has, and I'm going to start with one actually, Trung. So what is, when you look at the situation right now in Vietnam, in your particular hospital, first of all, how big is your hospital? How many beds?
Thank you, Dr. Quy. Now the situation in Vietnam is well under the control. We just only can you hear me?
Yeah, we can hear you and we can see you now, so that's good.
Yes. Thanks for your question. Now in my country, the situation is well under control. We just only have 1,148 patients with positive with the COVID-19. And I mentioned in St. Paul Hospital, we have 500 beds. My hospital is only screening for the patient. If the patient with a negative test, we transfer the patient to the national hospital for the tropical disease.
Got you. And when you look back at the peak, the status right now, I guess I assume that, as you said, that things are better controlled now. But when you're at the peak, what kind of resources do you think that your team, your hospital would have benefited the most from? What kind of help? Obviously, PPEs was a big deal, but logistically speaking, in the surgeries that you were trying to perform, what kind of resources do you think would have been most appreciated and needed?
Yes. With the visit of April last year, my department have a limited resource. We just only one operation room for the neurosurgical disease, just only one microscope. We have just only 14 beds, but the number of patients is always over with the number. So I hope that in the future, Missing Brain Foundation can help our team and our patient in treat aneurysm, AVM, and spine disease. Thank you.
Beautiful, beautiful. Go ahead, April.
Yeah, I was just wondering if they had any issues with supplies in terms of protective, like personal equipment, or did you have any trouble with that? Or were the numbers so low that you didn't have to worry about running out of supplies?
For the protection, we own the protection was supplied by the Minister of Health. So I think that we can help we can help us to protect with the COVID-19.
So I would take that there is probably the numbers are so low, and then the government had supplied all the PPEs and they were able to accommodate all the needs of your staff. Is that correct?
Yeah, exactly.
Very good. Well, wondering if there are any other questions. How is the status now in Vietnam? I believe there's 0 cases of new positives. Is that correct?
Yes, yes. For the long up till now, we passed over 1 month without the news case local in transmission.
I see.
And just to reinforce, this is remarkable, obviously, but do you know what is the numerator? I mean, how many cases are being tested on a given date or time recently? You know, because to have 0 new cases is quite remarkable. So that also, you know, makes me wonder how many cases are being tested at any given time.
I'm sorry, I haven't got the number exactly, but in my hospital, for all the patient or the member of family who arrive the hospital, we ask the question about the fever, cough, or history of traveling. If they have positive, if they have a symptom such as cough, fever, we have the rapid test, and after that the PCR test. Thank you.
Do you make it routine to test for COVID for any of your surgical patients, just in case there are some patients who are asymptomatic?
No, just only the patient with symptomatic with the PCR test. But the routine test is the rapid test with the sample are collected in the nose or the throat.
Thank you. We have one question here. Are there any vaccine trials that is undergoing in Vietnam right now?
Not yet, not yet.
And that's a good question, April, for the rest of the participants from all over the world to see whether or not in their particular hospitals or their countries, are they involved in any particular clinical trials? We know that in the United States, there are several companies doing trials and some of our institutions are involved, but it will be good to know, you know, from the rest of the world as we go along. So just remind us to ask that question.
Absolutely. I think that's pretty much it in terms of our question and answer. Thank you so much for your participation, Ken, and we really appreciate you being here with us today. And we are going to move forward to our next speaker. Thank you, and stay safe and healthy.
Thank you.
Thank you, Ken.
Thank you. Thank you, Dr. Kui.
My pleasure.
Sorry. Thanks, Q. Our next presenter is actually one of our own. We are just going to have an update on Mission Brain's state of affairs. Our next speaker is Will Arsheim, who's our treasurer here at Mission Brain. And we look forward to hearing from him. And we want to share with you what's been going on with Mission Brain as of late.
And then as a means of an introduction, I don't think people understand the relationship between us who began Mission Brain many years ago. For instance, the relationship that I had with Lisa, who was one of our nurses at UCSF, you know, who took care of me, who taught me so many lessons. The relationship I had with April, inside of the operating room, outside of the operating room, you know, dating back to 20 plus years ago. Same thing with Will, who would be there in the operating room helping us take care of patients. And of course, Mike, who was my professor, my mentor, and Dr. Berger, and so many people around here. That's how the foundation started. And this is what Will is. He's been remain loyal to changing the world, to giving people hope and using his own resources, help, dedication, and passion. And I just wanted to say that on behalf of all of us, that we've been so blessed. I personally have been blessed by all of you guys. So take it away, Will. There you go.
My name is Will Arsheim, and I'm one of the founding board members of Mission Brain and the treasurer. I'd like to thank all of you for your generous contributions, without which we could not do the great things that we do. We at Mission Brain are conscious of our responsibility to ensure that your donation is used to maximum effect, to further our mission of bridging resources and advancing international neurosurgery. To that end, we run a lean organization with minimal overhead. Our surgical mission team members receive only a small stipend in order to help them offset travel expenses. Our office space is donated and we have no paid employees. Keeping our overhead low allows us to put more of your donations to work. I'd like to take this opportunity to update you on a few specific ways in which we've furthered that goal during the past year. My day job is in surgical products distribution. I leverage my relationships with the manufacturers I represent and cooperate instead of compete with my competitors who believe in our mission in order to obtain donations of necessary equipment or to purchase at extreme discounts. Earlier this year, we organized a trip to Mexicali, Mexico, where the public hospital there was during neurosurgery holding the head by hand and drilling with a hand-cranked drill and removing the cranial flap with a giggly saw. We left them with a donated head holder from Black Forest Medical and a high-speed neurosurgical drill, purchased below cost from DePuy Synthes Ansbach. Later this year, we'll be sending a donated ultrasonic aspirator to Manila in the Philippines from Integra Life Sciences. Some companies donating in the past include Kinemed, Kerwin and Mizuho, and Medtronic. I'd like to thank them as well. I'm happy to announce the funding of our first Observer Scholarship program this year. We just awarded this multi-month international neurosurgical program to Andres Ramos-Fresnedo from Mexico City. He will start his program observing Dr. Quiñones at the Mayo Clinic in Jacksonville, Florida. Our usual missions last less than a week, but the lessons learned during this scholarship should last a lifetime. I'd be remiss if I didn't also thank the team at Hilltop for their tremendous work updating our branding and helping us get our message out. Those are some of the exciting highlights from a year in which our work has unfortunately been curtailed due to the pandemic. Despite the challenges, we at Mission Brain continue to push ahead to serve the needs of neurosurgical patients of limited means around the world. Please help us to get set to resume our mission trips next year by donating. The easiest way is through our website at missionbrain.org. Thank you so much.
He's going to say something.
You got muted, Will. There you go.
Thanks, Will. That was really great. And we are going to open this for questions as well for any of you guys who would like to know what's going on or how you could participate or anything that you would like to say or ask to Will at this point.
No clinical questions, please.
Will, it was an amazing. I got to tell the story of how we did that trip to Mexicali. Most people know that Mexicali is a small little town, on the border between California, Calexico, the United States, and Mexico, which is Mexicali. And that's the place in which truly yours here had the fence between Mexico and the United States back in 1987 to come to the United States. And there was an opportunity to do a very short trip, a very short lead that I gave Will and April and the board to go to Mexicali. It was literally between 5 and 7 days. And I was going to be there for 1 day, in the town that gave birth to me and who I am today. And Will and April did an amazing job. They gathered all this equipment that he just mentioned right now. And they drove down about 12 hours from San Francisco to Mexicali. And not only that, after being tired from driving all day, we got pulled over at the border and we were there for about 4 hours before they would allow us to pass with the equipment that we had. And then after that, they did a beautiful job donating this equipment to the hospital where I was born, a small little hospital. And the doctors were so, touched, and we were so touched that they opened and then they embraced us. But that's the kind of work that people like Will and April and Lisa and everybody else do. These are really, truly the unsung heroes. And I thank them very much. And the people there, the patients, the doctors, and we will continue to visit those corners of the world. And the next trip is going to be doing surgeries for those who don't have access to our institutions in the United States, but they still need to have their diseases cared for. So thank you, Will. It's a beautiful remarks.
We have a few questions that we're going to take. First, there's a comment from Dana, just great work. Well, thank you very much. And we really can't do this without the support of everyone else. No matter how big or small, your donations and your support really means a lot to us. So one of the things that one of the questions that we have here is what are the challenges of raising funds, and do small donations really make a difference, and how much difference do they make?
Thanks, April. Yes, absolutely. Every dollar makes a difference. As I tried to illustrate, we have such low overhead that every dollar we raise really goes to the ability to be able to provide equipment, small travel stipends, and we're continuing to expand right now with the fellowship that we've started. And we're actually just starting to talk about how we can do some individual patient support for some very extreme cases that we're presented with, and coming up with a method that we can do that fairly. So really, every dollar really matters. And I thank all of you who have donated in the past and all of you who plan to donate in the future.
Great. We have another question here. How do you leverage companies to get massive discounts? This is from Mary Beth. And are you available to become the Secretary of Health and Human Services?
That's funny. Thanks for that question. So as I mentioned, my day job is in surgical products. So I have professional relationships with several companies that I represent. I also interact with competitors. And so when we talk about Mission Brain, everybody is on the same team. And so through the time that we've been doing these missions, I have learned a little bit more each time about how each company has their request scenarios. So some of them are very formalized and some are informal. The other thing is too, our surgeons on the teams have relationships with these companies also. And so together, we're all able to motivate them to help support us.
Great.
And now, Will, Nina Flores, we have one question right here as to whether or not we have any plans to extend our work to functional neurosurgery.
Yeah, maybe April can take that on.
Yeah.
That is an area of expansion that we're planning on.
Yes, functional neurosurgery. Obviously, a lot of these surgeries have implants that are very expensive. So that's a little bit difficult, more challenging in that respect. But we do have plans to do that. And one of the things that we're looking at right now is some dystonia endemic in the Philippines, and how we can help address that, because the implant alone costs millions of pesos, which is far beyond the reach of these patients. So definitely that's something that we're looking at, not just in the Philippines, but in whatever needs that we find wherever we are working at the present time.
And the last one, April, and that would be worthwhile because it's been asked. A lot of people, you have, all of us have people who want to volunteer. So what's the process of becoming a volunteer, and how do we go about it as we think about the future? And of course, we're working under the limitations that the kind of work that we do, just for people to understand, it is truly the most complex brain surgery you can possibly imagine. We don't do simple cases. Even these cases are going to be complex in the United States, at the Barrow, at UCSF, at Hopkins, at Mayo. These are the top most complex cases that you can possibly imagine. So how do we deal with volunteers?
So you can send your information, and if an opening, if there's an opening for your skill set, then that's something that we obviously look at. However, like Dr. Quiñones has mentioned, a lot of these surgeries are very specialized. And because we really are trying to be responsible with the cost and who we take, and the other consideration is that we don't tax the resources of the places that we're going to. So we want to make sure that whoever volunteers actually serves a very important purpose in that particular instance. So we're very conscientious about trying to make sure that we do our selections responsibly, not just for the organization, but for our partners and for our patients, and also for the volunteer. We want to make sure that you feel like you've contributed to this this cause. There are other ways to volunteer or support the organization. Obviously, we have our fundraising drives and a lot of other things. Spread the word to all of your networks of friends and family and colleagues. And hopefully, as the years go by, we are a growing organization and we will be able to have other avenues for people to participate. So are there, let's see, I don't think we have any other questions at this point. So we are going to proceed with our next speaker. Dr. George Jallow is Chief of Neurosurgery and Director of the Institute for Brain Protection Sciences at Johns Hopkins All Children's Hospital in Florida. Welcome, George. So happy to have you here with us today.
Thanks, April. Thanks, Alfredo. It's a pleasure to be to join you virtually.
All right, we're going to go ahead with our presentation.
Good morning, good afternoon, or good evening. I want to thank Alfredo, Mission Brain, and all of you as participants for the opportunity to speak about pediatric neurosurgery and the training during this COVID pandemic. I think, as I said a little earlier, the wonderful thing about technology is that we're all able to get together regardless of the time. As you can see, it's late afternoon here in St. Petersburg, Florida, but it could be the evening in Europe, or it could be early or late morning on the East Coast. But regardless of our location or the time of day, we're here together to speak about education that has occurred during this pandemic. As background, on the next slide, a little introduction, and we all know about this. Really, this coronavirus, the SARS-CoV-2 virus, was first reported in January. However, it did appear in mid-December in a seafood warehouse or wholesale market in Wuhan, China. And early in January, February, the majority of the cases were reported within that province as a pneumonia of unknown origin. And as you can see, by December 28th of 2019, there were 4 cases. February 20th, there were 75,000 cases. And we really don't know the total number of cases that have been reported to date or will be reported to date, as this is ever evolving. It's probably underestimated, and that on average, the doubling time is somewhere around 7 days. Unfortunately, this pandemic has affected all our lives, both at home as well as at work. And predominantly, it's affected the way we teach and educate our mentees and others. The other important fact is that 80% of the symptoms appear to be mild, and really about 15% are severe and 5% are critical, with fatality rate on average is close to 2 to 3%, but some countries reporting as low as 0.8 and other countries reporting as in the United States, and you can see that that data is from the Johns Hopkins website tracking the virus. There's been 34,000 reported cases in the United States. There's been 1 million cases, and currently that's, in the United States, it's been about 200,000 cases, globally 1 million, and that's already old news. As of yesterday, it's even double that. When we look at Mexico, there's been close to 80,000 at that time, but probably more than 80,000 reported deaths, but probably more that are underestimated, as well as around the world. On the next slide, slide 4, you can see when we look at children in this, as reported to the CDC in the United States from February to April 2nd, you can see the increase of the number of cases that are reported each day in children less than 18 years of age, and the cumulative number of cases that have been reported. When we look at it, there's probably been in the United States, as of April, less than 3,000 cases. It's probably now on the order of probably just a little shy of 10,000 cases. And similar to the adults, again, probably 20% are hospitalized, 60% are infants, and unfortunately, there have been fewer deaths as reported in children as compared to the adults. And on the next slide, you can see that when we look at this, of the cases that were in this published report from the CDC in April, when we looked at the pediatric cases, 15% occurred in children less than 1, and the vast majority occurred in children older than 10 but less than 17, accounting for 50% or so of the cases. However, on the next slide, you know that the incidence of the COVID-19 in children, true incidence is unknown, really due to widespread testing and really the prioritization of tests for adults with the more severe illness. And we do know that there are fewer cases reported. And while children comprise 22% of the U.S. population, really only 7% of all the cases with COVID are found in children. So, I think this is important, especially when one is practicing in a children's hospital. I can attest to it that this, at our hospital, which is 260 beds, we have had 0 hospitalized children for the last 2 weeks. And that's even with the schools reopening as well as children participating in sports. So, when we look at it, what does it look like to the lay press? Here's some publications out of Florida that nearly 1/3 of the children tested for COVID in Florida are positive, and that they're, although they're not being hospitalized, we don't know what the long-term risks are for this. And the reason, for this is that there's probably a large number of children that are asymptomatic and being tested. On the next slide, you can look at the international data that when we look at the children that of the 6% that were tested in Iceland, children less than 10 were less likely to be infected than those over 10, from what was stated. And that the same thing holds true both in Europe as well as in Asia when we look at the numbers from South Korea, Italy, and Spain. And on the next slide, so, let's get to the conversation at hand. And really, what has COVID done to residency training programs? You can see that all the rotations, residency, were all paused on April 1st of 2020. This occurred in the U.S. and really that there's no rotation, that they were asked to stay in place, almost like a shelter-in-place order. And other things, that did occur is what happens with the board examinations that had been scheduled for the spring. Many, if not all, were canceled, both here in the United States as well as in Europe. And that, as an example, for the neurosurgery board examination, that was paused and rescheduled 6 weeks following the initial scheduled date. And In addition, there, on the next slide, slide 11, you can see that in Europe they're working with the government as well as the Academy of Medical Royal Colleges to discuss what would happen during these circumstances. The other approach was really on slide 12 was what happened to the CME educational conferences. And you can see some of the postings here that says, all external meetings and events have been canceled until Tuesday, June 30th. That was early on, and we do know now that this has even been extended further and that there have been very few, if any, in-person meetings that have been held in place. The AANS meeting, April of 2020 was canceled. So the April 25th to 29th canceled and rescheduled for the following year. And then on the next slide, when you look at the CNS meeting, the 2020 CNS meeting that was scheduled in September, you can see that that was rescheduled to October 16th through 20th of 2020. And that meeting, which will be held in Austin, Texas, will have the same theme as the 2020 meeting, and really will have two presidential addresses given it will be a combined meeting. So in terms of pediatric neurosurgery meetings, if you look at slide 15, the American Society of Pediatric Neurosurgery, which meets in January 2021, that meeting has been postponed. The section meeting that was scheduled for December 2nd to the 4th was reorganized to be a completely virtual meeting, and it was brought down from 4 days down to a 3-day virtual event, and really with two half days and one full day for December of 2020. Following this, on the international front, in terms of pediatric neurosurgery, the European Society of Pediatric Neurosurgery meeting, which was scheduled for April, has now been rescheduled to next year, to May of 2021. So, you can see that the educational programs have taken a significant impact. Another international neurosurgery resident course, the 5th annual that was originally scheduled for April 1st to 4th in India, has been postponed to 2021. So you can see clearly there's been a significant number of meetings that have been dramatically affected by COVID. And if we look at as we move forward, there's still many meetings that have yet to be scheduled. The International Pediatric Neurosurgery, the ISPN, that was originally scheduled for October of 2020, has been also rescheduled to November of 2021 in Singapore. And hopefully, the attendance. Other venues that given that these in-person meetings have been canceled, now really the educational opportunities for pediatric neurosurgery are really through technology, whether it be Zoom, Microsoft Teams, Skype, Facebook Live, or other, or even WebEx. Many opportunities exist for education, as seen by the ISPN offering. And the Clash of Titans, you can see two of the, as they call them, episodes, really two speaking engagements looking at one at epilepsy and then the other comparing open versus the minimally invasive endoscopic repair for cranial synostosis. Other topics that have been discussed have been epilepsy, tethered cord, as well as women in neurosurgery. Looking at other opportunities is really the International Pediatric Neurosurgery Collaborative. I encourage everyone to attend. This was a webinar that was held July 25th of 2020 and brought together many thought leaders in pediatric neurosurgeons from around the world for a day of web-based lectures. Another is the Virtual Journal Club, as we see it. There's one just held this past week, October 18th, bringing together three pediatric neurosurgeons from around the world to discuss three impactful journal articles that relate to pediatric neurosurgery. And some of the topics include shunts, the Chiari external consortium, as well as cerebellar mutism following tumor surgery. Without this, I must highlight a program that we're offering, our Pediatric Brain Symposium that was originally scheduled for November of 2020 in person is now completely virtual, and we will have international speakers covering the whole host of both neurosurgery, mental health, as well as neurological disorders. I encourage everyone to attend on this meeting. What about in-person training or boot camps? You can see that there have been three sessions that have been canceled, as well as the intern boot camps that were canceled for July. All have become virtual. Grand rounds within our organization, both at Johns Hopkins, have all become virtual since March. And the wonderful thing about this is it really has increased the attendance from 50 to almost 150 participants during these Zoom conferences. And you can see here one of the keynote lectures that was being given was on peripheral nerves and the viruses involved. The other, you can see that at University of South Florida, there's more of a collaboration within the national organizations to have virtual visiting professors speaking from around the globe with many different topics. And finally, what has it impacted residency surgical training, both the outpatient, inpatient, clinical lines, general medicine opportunities, the supervision, and we can't forget about the operative cases. The Surgeon General recommended halting all cases in March of 2020. When I looked at the state of Florida, the governor mandated an executive order on March 1st, mandating the halting of any elective procedures. Any case, as you can see on the slide, that was going to be completed at our hospital required a form to be completed, ensuring that this was a urgent or emergent procedure and not a non-essential elective procedure. And that went into effect for almost 8 weeks' time. Other meetings, when we look at this, you look at the ACGME and their decision regarding visits, educational activities, and other meetings. And the ACGME's response to the pandemic was business as usual, increased clinical demand, or emergency status. There have been, fortunately, we've had many papers published on neurosurgery resident training during this pandemic. One was from Italy, looking at their perspective. It was 18 questions, web-based, that was asked in May. And what they found was that that most, if not all, the Italian neurosurgery residents reported significant changes both on training and education, and really prompting a change in their educational activities to maintain competency in their training program. And that was a paper published in Active Neurosurgical. Another publication that we can look at, as you can see there, you can see that almost 2/3 or 3/4 did affect as compared to the others, and that their operative volume was decreased 70%. But the other resident survey that occurred in a North American survey that came out of Boston really looked at the impact, and this was 31 questions. They looked at 30 states, including Canada, and that again, similar to the Italian study, 82% reported that their inpatient of operative volumes decreased by about 40% 40 to 50%, as well as a significant reduction in work hours, and there's a significant increase in resident didactics. And you can see that that it was across the spectrum of residents throughout. And when you looked at the hours a week for didactic teaching, you can see that there's a significant increase to the number of hours per week of didactic lectures as compared. And when you look at the clinic visits during this pandemic, and especially when we focus on pediatrics, as you can compare it, you can see that in April 2019, at one center, they had over 34 in-person visits for pediatrics in 2019. In March, it was down to 36. However, by April, it was only one visit for the experience. And you can see that their experience, the number of patients during these weeks dramatically decreased when you look at the April 2019 to the April 2020 volumes. It has slightly increased over time. However, this has not returned to its full baseline. Another paper from USF looking at the impact at another tertiary care center. When we looked at this at South Florida, you can see that the health system there, the neurosurgery department, created a plan where was to allow the team to work in units to be able to provide care for the patients that were being treated emergently, and that the teams were divided into 3 teams with an attending, 3 different attendings, and 3 different residents on each team, canceling all elective surgeries and conducting the majority of the visits via telemedicine and the virtual or the lack of in-person grand rounds. And you can see in terms of the number of volumes or the cases that were performed during this period, you can see that when you look at it, most of the cases that were being performed were really emergent or urgent, and the pediatric volume really was, these were all traumas that were being performed given the amount of accidents that occurred. Another, when we looked at ground zero here in the United States at the Mount Sinai program, looking at how the educational programs were changed, you can see that at Mount Sinai, they broke their teams into a COVID unit, a neurosurgery hospital practice, as well as the neuro ICU, and that there was really a 60% reduction in the neurosurgical census during the outbreak, and that they really did the number of admissions peaked similar to COVID that was occurring in New York City at that time. And you can see that during this period of time, they had a volume decrease of close to 80%, and that only 5 pediatric cases of the total 72 neurosurgical procedures did occur in children. So I think really when we do summarize it, it's really that the pandemic has restructured the education for all learners, whether it be the consultants, the fellows, the residents, or the medical students. It's changed their clinical experience significantly, may have improved their research experience, and really, the new norm has become Zoom, WebEx, Microsoft Teams, and Facebook Live as venue for the didactic. And really, what about the hands-on experience, given the dramatic decrease in the operative volume? I think time will tell as we recover from this pandemic, although it continues to linger, if the volumes will return and will allow the residents to gain the necessary experience in pediatric neurosurgery. And I do want to thank you all. And in terms of my last slide, I will highlight our virtual symposium. All are welcome to attend. in 2 weeks' time in November, and it will be a phenomenally completely virtual conference. And at the end, I do want to thank you all for allowing me to participate in this program. Thank you so much, and I look forward to any questions.
Great. Thank you so much, George. It was a very interesting presentation. One of the things that I actually realized is that this whole live symposium that we have right now stem from all these things we're learning about adjusting and learning and information in this age of in this era of a pandemic. So anyway, we're gonna have question and answers here right now. I don't see any questions at this point. Q, do you have any questions on your end?
I do actually, George. Thank you. Beautiful. As everybody knows, George and I go back to 2005 when I first went to Hopkins, and since then he mentored me. I learned to do a lot of surgeries with him, and then we started going around the world in these missions. And I'm always been fascinated by the emphasis that he puts on education. He's been a tremendous mentor. So when you look at this, George, you know, particularly for pediatric neurosurgery, where the cases are limited, where the training is limited during residency, and then in fellowships, is very, very tailored to the needs that these the fellows have. Given this pandemic, how has this affected the training of your fellows, and how do you think we're gonna need to think about training, you know, in the future if things like this continue to happen? And of course, a lot of the hospitals closed, even though children, as you know, showing your numbers, they have less, you know, infection rate and also less morbidity. So how do I adjust to all those things?
So, Alfredo, great question. I think, you know, with the pandemic, our volumes dropped by 50%. So, you know, for the resident and the fellow, for 3 months, they did 50% less than a fellow or resident that was there the year prior. So clearly, the hands-on experience is suffering. They don't have the exposure. And you know, and I know, the more you do, the more experience you have, the better prepared you will be when you finish. So I think hands-on, they've all the residents and fellows have suffered. You know, and we've looked at it from organized neurosurgery. Do we have to lower the number of cases that a resident has to do to finish up a 7-year neurosurgical residency? I think we will. I think, you know, the board is going to have to recognize that. What also has changed is really, I think, the webinars and these virtual opportunities, they've just ballooned, blossomed, skyrocketed. I mean, if there's a lecture on pediatric neurosurgery every week. So I think we've made up for the hands-on with more of a didactic opportunity for them. At the end, I still think we need to get them their hands-on experience. And I think, you know, given that their peds rotations are limited, I think some residents their training will have suffered during this pandemic. So I think we'll have to stay tuned and see what happens when they finish their training and see what kind of pediatric neurosurgeons they become.
Thank you. And a follow-up question, Josh, if you don't mind. You know, I was thinking about, you know, you lead the entire hospital system right there with the work that you're doing. Right before, when we have Carla Venegas, she was talking about the neuropsychological consequences of this virus on their patients. Do we know much about the potential ramifications on children, you know, so far with the limited data that we have? You know, that's something that, of course, as parents, as providers, it worries us.
Yeah, no, I think Caroline, you bring up a good point. What I know is that our mental health, our psychologists, our psychiatrists, during this pandemic, their volumes increased by 70%. We are fortunate enough that we are able to do telemedicine for these families and for these children. Now, is it because we had that platform that's available that allowed easier access for the children and the families to reach our mental health professionals? or was it the pandemic that created the need for that? So yes, I would say, you know, the volumes went up 70%. I think making it easier with telemedicine does contribute a little, but the majority, I'd say, you know, the majority are because of the stresses that these children have sustained. The other point I will say is the one thing that we noticed at the Children's Hospital that really, I am surprised that we, you know, society hasn't mentioned it, is we saw, given that we're in Florida, the weather was warm, we saw a threefold increase in the number of drownings during a 6-week period in April as compared to the year prior and 2 years prior. And the reason for that was the stay at home. The children were at home. The parents are at home. They might not have been watching them. They had access to the water. And so we had, you know, in 6 weeks, we may get 2 drownings. We had about 10 or 12 drownings in that 6-period period. So again, another stressor, mental health for these young children. So thank you.
Amazing points, George. Thank you for all the work that you do and all the stuff that you're doing. And thank you for giving this beautiful talk.
Thank you, Alfredo, Lisa, April, and Will, and everyone else. The one thing I personally miss is as I said, you know, the hands-on. I miss our opportunity to go out and travel and help the local communities. But I think you know, what we're doing today virtually sure makes up for what we can do on the ground.
Thank you so much. I do miss all of you guys and hanging out with everybody. Obviously, it's not just all work, it's also a lot of fun, and we keep our connections that way. We're going to move forward to our next presenter, but before that, I'd like to introduce Lisa Hannigan, who is our secretary. She will be taking over as moderator from this point onward. Lisa?
Good morning. Thank you so much to everyone for joining us, both the presenters and the attendees. We truly appreciate it. We're going to move on this morning, and our next speaker is Ramiro Del Valle, and he is the chairman of neurosurgery and the director of the Gamma Knife program at the Medica Sur Hospital in Mexico City. And Ramiro, we are so delighted that you have opened your doors to us and allowed Mission Brain to work with your hospital and gotten your hospital to donate so much to our program and to the patients that we operate. So thank you very much, and take it over.
My pleasure. It's my honor. We're ready. Good morning to all. I appreciate Dr. Alfredo Quiñones for having me in this symposium with regards to impact of COVID-19 and neurosciences. The pandemic was declared by the WHO on March 11, 2020, and 3 days later, Medica Sur registered the first patient. The first death in Mexico occurred on March 18. The health system in Mexico has a population of 127 million, where Social Security represents 88%, and the rest correspond to the private care. In Medica Sur, the first action was hospital conversion, assigning the general ICU and the postoperative recovery beds with an expanded capacity of 18 beds for respiratory ICUs to COVID-19. A separate floor of the hospital was assigned for non-COVID ICU. The 4 and 5 floors of the hospital was assigned to COVID patients, representing 23.8% of all hospital beds. Additionally, the respiratory emergency unit was built for triage with internal communication to the emergency service. The operation manual for COVID patients was also developed. 85% of public hospitals were assigned only for COVID patients, and private hospitals became mostly non-COVID-19. The tertiary level private hospital focused on the care of non-COVID patients from the public sector with the altruistic participation of health workers. This is a historical image of downtown Mexico City in confinement. due to the confinement restriction, patient mobility to hospital was reduced, and a stay-at-home policy was promoted. In the graph, we can see the negative impact we had on services of hospitalization during April and May. Moreover, elective surgeries in Medical Sur. There was a massive decrease in patients attending hospitals because the lockdown restriction, health minister and international guidelines of patient care, the fear of a hospital, even urgent health problems were neglected by patients and families. In our institution, the sharp fall of patient and procedure forced to administration to reduce the medical technician and administrative staff. In some services, up to 50% of the original staff. From March to September, 658 COVID patients were treated, of which 151 were in ICU, with an overall mortality of 5.1% and in ICU a mortality of 16.5%. The main comorbidities have been obesity, arterial hypertension, and diabetes mellitus. Serious complications, among others, have been acute renal failure, pulmonary embolism, myocardial injury, and acute myocardial infarction. Average hospital days prior to ICU admission, 7.8 days. Average days in ICU, 16.5. The global average of hospitalization, 24.3 days. Some negative impacts on the practice of neuroscience. For example, intraoperative neuromonitoring was reduced to up to 80% due to the delay in elective spine, skull base, and brain surgeries, among others. The protocols for anesthesiology were also changed, especially for transnasal surgery. The patient had to take a COVID test, and all the staff had to use goggles and N95 mask. However, the surgical team must keep in mind the possibility of symptomatic infection among any member inside the operating room. For example, when we restarted elective transnasal surgery in a patient with a negative COVID test, 3 members of the surgical team, the anesthesiologist, the assistant neurosurgeon, and the ENT surgeon, were asymptomatically infected. On the other hand, in the outpatient center of gamma knife surgery, we realized an evident increase of trigeminal neuralgia patients, shifting this diagnosis from 5th to 2nd place during 2020. We consider this phenomenon is a result of lower pain threshold related to major anxiety, depression, and panic associated to the pandemic. To sum up, according to the official data, Mexico has applied a scarce number of COVID tests. And due to this, the positivity rate is very high. In addition to that, Mexico is ranked as the 3rd place in most deaths worldwide. Finally, I like to stress that COVID has been a tragedy all over the world, and any doubt that for developed countries, the challenge is created due to the economical recession and wrong public political policies. However, let's move forward together. Life must go on. Thank you very much for your attention.
Amazing, amazing, Ramiro. Thank you very, very much, for this amazing data. Put it in perspective, so succinct, so eloquent. I have a question for you, Ramiro. As I am listening to this, and I am thinking about how we are going to be able to be ready for another event, because like George said before, Ted Schwartz in the morning from New York City, this is not going to be the last time, the last pandemic that we have. So how do you envision that we at Mission Brain together, of course, the work that you have done with Mission Brain as well, taking care of the indigent population there and medical. So how do you envision that we can help from Mission Brain, help places like Mexico City to prepare for the future?
Well, first of all, education and education. We have to keep in mind that everybody is infected. Until one cannot prove the contrary. Everybody is infected: physicians, health workers, patients, and family members. That's the key point. On the other hand, I will say that the radiosurgery is one of the best options to treat many pathologies. It's an outpatient basis. But we have to get more resources to provide this type of services, taking in account that this is a private hospital, in order to move all these services to the rest of the country. But I will stress that in collaboration with this fantastic program, Mission Brain, we have to continue in this collaboration. This is one of the best ways right now. It's through the webinar way. But I am confident that very soon we restart the collaboration physically in both countries, in very close contact with any country all over the world.
Maybe what we'll continue to do is plan for 2021 to, as we did before, come back to Medica Sur and operate in a lot of patients that need our help, that wouldn't have access, of course, to this amazing care, and continue to partner as we have done. And as Dr. Schwartz said in the morning, he presented some innovative ways to potentially be prepared to do surgeries in the future. I love to see how can we build those bridges and make equipment like that, ideas like that available to institutions like yours, to your team, which I know they're paying attention. You have them all signed up to pay attention to this. So that's what I'm thinking that is going to be the action item right here. But the situation, definitely Mexico is the third leading country in the world for deaths. And it's a country of a pretty large, 120 plus million people. Mexico City, 27 million people. I mean, your hospitals, the density is unbelievable, of course. So any last pearls for us, Ramiro, as we move on? We're going to hear from Praveen, obviously, about spine work after this.
Well, the big challenge for us is how can we move or to switch.
Someone else a little behind.
Sorry?
I think that you're unmuted, Will. We hear you working out or something, so.
Okay.
Continue, Ramiro, please.
Sorry. Well, for us, the big challenge is how we change or to promote how to switch the wrong political public. So it's a big challenge. Sometimes it seems that the private health system is entirely divorced of the public sector. This is our great challenge.
I like the way you're thinking. So maybe we can, as we have done, as you know, some of the trips that we have done, Lisa, remember, we have met with governors, we have met with secretaries of health. This is something that we can continue because I married those two systems a little bit more, as you said, the private and the public would allow to better healthcare system and will probably decrease the burden, the economic burden in society as in general. And that we got to do it. And we promise you that we'll continue to do it.
Thank you. We'll be ready.
Thank you.
Take it away, Lisa.
Thank you so much, Ramiro. I think one of the things that's most interesting here is the different, like you bringing up trigeminal neuralgia and how every different hospital and every different country has different things that they have noticed and worked on and developed with this pandemic. So thank you very, very much.
You're welcome.
Okay. Our next speaker is Dr. Praveen Mumineni. He is from UCSF. He is a vice chairman and also the Joan O'Reilly Endowed Professor in Spinal Surgery. And Praveen has really headed up a lot of our COVID work at UCSF. Please, Praveen.
Thank you so much, Lisa. Thank you, Alfredo, and Michael Lawton. I see is on there too, April. So many friends. Wish I could see you all in person rather than by Zoom. I've worked on the COVID response at UCSF along with Mitch Berger, who will be speaking later, and also with our residents, John Burke, Andrew Chan, who did a lot of the work behind the scenes on this talk. So I'd like to share that with you. And I hope that this pandemic ends soon and we can all meet again in person. I think
Hello, my name is Praveen Mamaneni. I'm going to share with you the UCSF experience with COVID-19. I want to thank my co-authors, my fellow Tim Lockney, our chief resident Andrew Chan, our senior resident John Burke, research coordinator Josh Rivera, and Professor Berger for collaborating with me on this talk. So I do have some disclosures which are here. They're not directly related to COVID. So COVID has been a real problem in 2020. The Centers for Disease Control of the United States has proposed to postpone surgery in case that there is insufficient amount of PPE available and too many patients with COVID in the hospital, and has suggested some tiered approaches for this. There's been a lot of COVID in the United States. This is our regional map showing our tertiary and quaternary centers, and the major academic medical centers in the large cities have seen a large surrounding area with COVID. In neurosurgery, the question is, can you postpone surgery in the face of a COVID pandemic, or do you have to proceed with surgery? There are certain cases like malignant brain tumors or severe cervical stenosis with myelopathy that do need to be operated. There's other cases that are not as urgent, like a herniated disc, unless it has foot drop. So neurosurgeons must balance urgent surgery with limited resources during a pandemic. Do you have enough patient protective equipment? Is your blood bank stocked? Do you have enough ventilators in your hospital for the patients? And how is the ICU space? Are all questions that we need to answer. So in order to answer these, we had a publication in the Red Journal, which was the cover article in the summer of 2020 on COVID-19 pandemic and a neurosurgical treatment algorithm. And this is our protocol at UCSF, which we created with department leaders from multiple different departments, including anesthesia, neurosurgery, orthopedics, infection control, etc. And we formed this multidisciplinary surgical committee with all of these doctor champions from different departments. And then we synthesized a protocol around our PPE and our testing parameters. And then we implemented the protocol, and then we did a Delphi in order to gain consensus amongst the experts. And then we repeated the cycle several times and iterated to get the system to work well and to achieve our final protocol. So what we looked at is surgical acuity of our cases, perioperative preparations, how much patient protective equipment do we have, and do we have the capacity for post-op care with space on the wards and ICU space and ventilator availability. So there is some ambiguity in the Centers for Disease Control triage algorithm. That triage algorithm would typically put neurosurgery in tier 3A, which means you should not postpone the cases because the patients have high acuity surgical issues. And here's some examples of type 3A cases in neurosurgery: a meningioma, a glioblastoma, and a subdural empyema. Now, all of these three cases are not equal. The subdural empyema is emergent surgery. The glioblastoma should probably be done within a couple of weeks. The meningioma could wait a little bit longer, but needs to be done as well. So just because we have them in tier 3A does not mean that all the neurosurgical cases are created equal. So in order to take a look at all of these issues, we created a surgical protocol with all of these different kind of parameters built in. So what is the disease in our community was the very first question. If we have very few cases in our community, less than 1 in 100,000 cases that are testing positive, then we're in the green. And if we're in the yellow, we have 2 to 9 per 100,000 new cases of COVID. And if we're in the red, we have more than 10 per 100,000 cases of COVID. And we have to understand that these are tested cases. So we know that the patients who have COVID who do not have a test and go unrecognized could be several times, maybe even as much as 5 to 10 times higher than these numbers. So these are just the testing cases, and this is how we stratify how much COVID is in our community. San Francisco, for much of 2020, was in the red zone with more than 10 per 100,000 new cases of COVID in the community. because of that, we really restricted visitors into the hospital. And you can see the hallways are empty of visitors, and we only let in patients who need to have treatment because we're trying to avoid getting into this black zone. In the black level, there's an overwhelming pandemic. All hands are on deck. You have more than 50 plus patients per 100,000 who have COVID, and you're starting to run out of ventilators, et cetera. Thankfully, San Francisco never ended up in the black zone, but New York City did. If we had the black zone, we were going to reopen our closed and shuttered old hospital wings, and we are going to try to house patients there as our backup plan. As far as surgical acuity, we have to really look at surgical acuity for these COVID patients. As I said before, not all of them are created equal in neurosurgery. If you have a subdural empyema, it's emergent, you have to do it within a few hours. If you have a cauda equina, you should do it within 24 hours. If you have a spine fracture, we should try to do it 24 to 48 hours. If you have a high-grade glioma, probably within a week, and a high-grade glioma with no shift, perhaps within 2 weeks. So not all the neurosurgical cases are equal. So we subclassify them into emergent, urgent level 1, 2, 3, and 4 in order to define which patients needed to go first. In the green level, you can proceed with all cases because you have lots of capacity in the hospital. Currently, we are not in the green level. We are actually operating in the in the yellow level in San Francisco now in October 2020 because we have 2 to 10 patients per 100,000 who are testing positive for COVID in the community. And in much of the summer of 2020, we were at the red zone, which is more than 10 per 100,000. So when you have the red zone of the cases in the community, we're doing about 50% capacity. In the yellow zone, we're doing most of our capacity. In the green zone, we're doing all of our capacity of level 3, 4 cases, etc. So this is how we're stratifying which cases need to go based on how much capacity we have. And if you're in the overwhelmingly bad black zone with lots of patients in the community and you have to have field hospitals set up to treat the patients, we stop doing elective surgeries altogether. So what about surgical transmission of COVID for these patients? So this is a article in Lancet Respiratory Medicine, which really caught our attention. 14 healthcare workers were infected by a single patient in Wuhan who had surgery. And then of the 14 people who had that surgery, it was an endoscopic pituitary surgery. And there is a good number of doctors who passed away because of their exposure. So we wanted to be very careful in San Francisco not to expose our medical staff. So therefore at UCSF, what happens is all patients get tested before they go to the OR unless it's an emergency case. And the entire team who's in the OR wears N95 masks during intubation and for the surgery unless we know that the patient is tested COVID negative. And even if the patient is tested COVID negative, we know that there's a window where they may test negative but really be positive. And so we are recommending N95 for all of our anesthesia providers and ask everybody to step out of the room during intubation and extubation for about 15 minutes to make sure no aerosolized COVID particles, coronavirus particles are being inhaled. UCSF has risk stratified our procedures, endoscopic, anything in the craniofacial sinuses are high risk and level 3, and we recommend that the people in the operating room wear N95 masks. Level 2, general anesthesia, you have N95s which are optional, and all the patients are typically tested for COVID here. And if it's a local anesthetic, you may not need to wear a N95 mask depending on your PPE availability at your hospital. We do test all of our patients at UCSF. All elective surgery patients are COVID screened the day before surgery and must have a negative COVID screen to come and have surgery. Transferred in and urgent patients are treated as if they're COVID positive and quarantined until their inpatient COVID test comes back, which typically takes us about 12 hours. We do carefully watch how much PPE we have. We have now a supply of more than 6 months of PPE on staff. So we are currently doing well. The beginning of the pandemic, we needed to get more PPE available. This is looking at viral transmission. PPE is best if you have an N95 mask and as well eye protection. So for anybody who's having pituitary surgery, we would recommend that they do that. We can use less N95s for patients who have lower risk procedures. And we want to make sure that we don't have spread of the COVID virus by aerosolization and getting it into your eyes and your nose. As far as a checklist, we have a preoperative checklist, which we started here. We have to verify that we have enough OR personnel to do the case and no one is out sick. We verify we have implants available. We verify we have pathology staff available. And we make sure we have postoperative bed before we go to the OR. If the patient is COVID-19 positive, we get infectious disease to come see the patient and put them in a negative pressure room and isolate them. As far as postoperative care, if the patient is going to the ICU, we notify the ICU team of an admission and we tell them about the COVID status of the patient, either positive or negative, and verify that a bed is available. And we check the bed availability before we start the cases if they're elective cases. We also notify the floor and nursing unit manager to make sure they have enough PPE to treat these patients. Post-hospital care can be difficult during the pandemic. After they finish their hospitalization, they have to go to nursing home or rehab. Our rehabs in our local area are now accepting post-operative patients, but they want them all to have COVID tests before they send them to the nursing home or to rehab currently. So in conclusion, what I can tell you is the CDC protocol for specialties is not really targeted for neurosurgery, so we made our own protocol. Surgeries do need to proceed for neurosurgical emergencies, even in spite of the pandemic. Our protocols are giving some guidance on how to do it. They're not perfect, but they certainly help us to limit the amount of PPE that we're going through. Here's a quick case example that we can talk about. This is a 63-year-old with prostate cancer, referred for meds to the thoracic spine. I saw the patient with telehealth. He has a pathological fracture here with severe stenosis. He's paraparetic. You can see the cord compression here. So he has a SIN score of 13, meaning he has an unstable fracture. He goes into the tiering system here. He would be in the red zone, a proceed case because he's a level 2 case with impending neurological deficit. So if he is coming to the hospital, we like to get him COVID tested, and if not COVID tested immediately, we would wear an N95 mask. And we did the surgery for him using percutaneous fixation and a mini open approach to take out the tumor, and then putting some vertebroplasty cement to stabilize his spine. And we got him through this even during the COVID pandemic. So I'll stop there and see if there are any questions. I thank you very much for your attention.
Praveen, beautiful talk. Thank you for your amazing work, and especially that last case illustrates the complexity. Just to put it in perspective, just so people know, Praveen was my chief resident when I was a junior resident at UCSF, and Lisa was the nurse taking care at the time, also Dr. Wilson and Dr. Berger. And at one point, Praveen is not foreign to taking care of many, many patients. At one point, it was just Praveen with two residents running a service where we were doing almost 5,000 surgeries a year with multiple rooms, sometimes up to 12 operating rooms going on at once. So he knows how to deal with this chaos of doing and multitasking. Praveen, when you look at that experience that you just went through at UCSF through the pandemic, what would you tell our young generation, the young surgeons that are coming up, because this is not going to be the last time you're going to deal with something like this, Praveen? So what would be your words of advice for them?
Yeah, I think, Alfredo, I fondly remember when we were residents together in the 90s, and we had to make do with insufficient resources because it was so busy. We were down a resident. And this is like what pandemics do. They really stress resources. So we have to become creative. We have to become hyper efficient. You're basically trying to stay 2 steps ahead so that when you know that there's going to be limited capacity, we try to put the number of patients through the system as best we can with limited capacity to save the most number of lives and take care of the most number of people. I think that sometimes this is not taught, it's learned by watching how other people do it. And I think, we have to set a good example for those who are training now so that, in the future, when you and I retire, and then the next generation takes over, that they're ready to go, because I think as all of you have said, that this may not be the last pandemic that we face. Having help from people who have been there for a long time, like Dr. Berger, and having insights from many colleagues and friends. Lawton was here for a long time. You were here for a long time. Wonderful nursing staff that we hear, including, Lisa and April, who had put in so many years here at UCSF. I think with a team like that, we're bound for success.
So the key right here is multidisciplinary. I noticed the first slide that you had was for these protocols that you guys implemented for several surgical specialties like neurosurgery. There were many teams that participated, and obviously that's key for what I see from your work.
Yes, I think that's correct. Being very collaborative, reaching across to the other departments because they all face similar problems. They're trying to get their patients taken care of as well. So trying to get everybody to come together and unite and go forward with one mission really helps to get the job done. Very important to work across the aisles.
Praveen, I have a question. If I noticed that that the rehabs all closed down, the outpatient physical therapy closed down, what kind of impact did that have on the recovery of your patients that did have surgery?
Yes, that made it very difficult, Lisa. We had to recover some of the patients in the hospital until they were in a situation where they could go home. We had other patients who, had no family resources or home resources. They lived alone and they were kind of stuck with us until the rehabs or the nursing home started to reopen. That did start to happen sort of a month in. The only benefit that we had is because we canceled all our elective cases, we had space to keep these people in the hospital until it was safe to discharge them. But it really slowed down the system. Because the rehabs did not want to take patients in. And of course, the nursing homes don't want to take them in and then infect all the other elderly people who are there. So you can see why they would limit the number of transfers in. But eventually they did take the patients as long as we would test them the day before for being COVID negative. And then they would take the patients into the rehab in the nursing facility.
Wow. Thank you. That was a fabulous presentation. It's such a good system and organization. Thank you.
Thank you so much.
Okay. Our next speaker this morning is Dr. Rodrigo Ramos Zuniga from Guadalajara, and he is the director of the Institute of Translational Neurosciences. He is a neurosurgeon, and Rodrigo was the first person to welcome Mission Brain to Mexico, and that was the first trip that anyone took with Mission Brain, and it has been such a pleasure to have a relationship with you and to go to the 2 public hospitals in Guadalajara. And we thank you for being part of Mission Brain.
And if you allow me, Lisa, I have another meeting, but I've been waiting. As you can see, my other meeting's already taking place. But I wanted to say something about Ramiro, because Ramiro, as you said, in 2011, when all of us went together, he opened the doors to what we are doing today around the world. It was really symbolic. And Ramiro had opened his doors, Rodrigo had opened his doors way before that in 2006, beginning to invite us selectively doing different work. So he had this vision 5 years prior to the very first large trip that we did together. And I think that Rodrigo has been an amazing friend, and we all have amazing fun memories. I just wanted to say that because he's been an inspiration to many of us. And I leave you in good hands, Rodrigo, with our team right here. I'm going to move to another meeting, and I just thank you from the bottom of my heart.
Thank you for this kind invitation. Good morning for everyone, and it's a pleasure to be with you. Thank you. Go ahead. Hello, everybody. Thank you very much for this kind invitation to share some words in this scenario of the Mission Brain. I am very proud of this project with great friends in this great journey to work for the other people, to share our knowledge, to share our experience, but especially to share our human being sensibility. In this time, I like to say again about my recognition and thank you to the team in the different parts of the project for the preparation of the schedule, surgical work, conference, support to students, support our residents, and support especially for the people. My few words is related to the first announce about this event I put in Twitter, and I like to share with you. Many years ago, we started the dream of sharing medical knowledge and care with the generosity of the world leaders in neurosurgery. Now, in times of pandemic, we continue with this vocation. And part of this presentation, I like to share with you my last paper related with COVID and the pandemic times. This is the name of the subsequent cures of the COVID in the society. It was published in this week in Archives of Medical Research from Elsevier. And I like to share some words about this paper with you because it's part of the contemporary scenario for all people in the world. Beyond the strict biological scenarios inherent to the virus, other consequences exist that require attention for us. This is related to the alternative implication of the pandemic in our society. In the first time, our primary focus, of course, will be oriented to the treatment of the disease, to management of the consequences of the infection of the virus, and this is directly related with the physical deterioration of the patients. The accuracy of the natural history of diseases, the containment, the mitigation strategies is part of the great work in all worlds. Additionally, we research about the eager search for remedial alternatives and the future of the vaccines. In the second curve, we need think in the other scenarios. The deferral of the elective procedures of the chronic disease and even some non-COVID infection have started to have an impact on the numerous cases. One third curve is related with the social consequences and comprise of the official regulations of the confinement and eventual suspension of non-essential activities and their consequences. This situation have repercussions in local employment and economy. We have a fourth curve related with the physical and mental conditions of the professionals of health and the people. We have many days in confinement, and now we have consequences directed with the anxiety, depression, uncertainty, and related with the mental consequences of the physical disease. This situation have an impact in healthcare professionals. We know the burnout syndrome with different repercussions in the mental condition and emotional situation and the physical situation of our professionals. We need to think about the quarantine related to the physical separation of the people who have been exposed to an infectious disease. But the isolation is related to the strictly applied to persons that suffer with the infection. It is important comment about the isolation is in the physical distance, but not necessarily related with the social distance, because now we have more necessity to work and stay together, all together by different ways. Like this way, we are working in this project, this great project as Mission Brain. Consequently, the instruction of the sanitary structure in different parts of the world must be sustained in legal basis. Authorities must be solid, convincing, scientifically supported, respecting of civil rights without becoming a state of emergency. The current interpretation related with the immunity passport, which is obtained through diagnosis, laboratory diagnosis, can be achieved in different scenarios. The situation today in the world, the disease, inherent social risk, and the environmental context in the disease risk itself. The relevance of the bioethics is now in the table for the main decisions, because the position And the vocation of the bioethics is preserving the fundamental rights in a crisis scenario related with the looking for the critical roots and to get a greater balance and a part of discretionary decisions. Certainly, many collaterals have emerged from these curves, and in the case of the challenges, new challenges is related with the convert the aspirational precepts to proactive proposals basis what are now called more determinants of health. This is to say that the right to the life, the right to the health, have a universal character inherent to dignity without the interpretative confusions of any state in the world. The respect of the physical and emotional integrity for our patients and for the people is a new challenger and among the people and the society. These sanitary guidelines must not be the cause of the social discrimination or stigma that can be associated with the management of such data, and in any case take in account the moral determinants of health and the social determinants of health in the make decision for a specific socio-cultural context. It is the permanent task of the bioethics to anticipate these conditions. This approach are particularly oriented to those who are primarily responsible for decision-making in matters with an impact in public health. With this message and with this idea, this project Mission Brain touches the feeling and touches the respect for the people to work in this altruism project for the future. We are in a project related with the education, with the moral values, with the principles, with the deontological codes and ethical codes. For this reason, it's for me a pleasure to have the opportunity to refresh these foundational principles of our project related with the Mission Brain. Thank you again for this kind invitation, and I send for you my best wishes for your health and for your country, and we are working in the same project and in the same way. Thank you again.
Thank you so much, Rodrigo. Very thought-provoking. I think that your country and our country have been caught very much in this bind of independence versus government, where how the government steps in, and we appreciate it. Appreciate your presence.
Thank you, Lisa. In fact, I think we have the responsibility just now to be and to take the leadership, not only in the surgical room. We have a social responsibility, especially in the times with the infodemic. We have many quantity of the information, fake news. This is the infodemia now. For this reason, it's very important they make decisions under scientific view, and we have a specific responsibility in this area. I think the neurosurgery is a leadership in this moment, and we need to take the best decision, not only for the surgical procedures, if we need team in the society. And Mission Brain is a very good example about that. Thank you again.
Thank you so much. If I don't see further questions, okay, we will move on. Our next speaker is Dr. Mitchell Berger. from UCSF, University of California, San Francisco. He is the Berthold and Bell and Guggenheim Professor of the Department of Neurological Surgery, and he is also the director of the renowned UCSF Brain Tumor Center. So I don't see, Mitch, are you here? I don't think he's been able to log in yet, so we'll go ahead with his presentation.
Well, thanks very much for allowing me to participate in this meeting. Very important symposium on the implications of COVID-19 in neurosurgery. I'm going to take you through what we did in San Francisco at UCSF and some of the lessons we learned with this process. And let me start by first thanking John Burke, who's a resident in neurosurgery. John did a great job in helping to put this whole thing together, along with Praveen Mumanetti, one of our other attendings. We all participated in this process. So if you think about this, basically, we all know the story of when COVID first evolved back in December outside of our country. Things started to progress in March in terms of the number of cases. We had basically 0 in March. And then clearly things got out of control in San Francisco, and we had an escalating number of cases in our state, along, of course, with New York. We were not as bad as New York, but it was certainly very, very difficult. And early on, our mayor put a shelter in place along with our governor. And so we were one of the first states to really lock down in this process. So how did we deal with this? Well, I think the first situation was to develop a plan with CDC guidelines, although this was a moving target, and it was really not clear early on what all the aspects of the process were going to be, from PPE to precautions to blood availability, all those kinds of things. And most importantly for us as surgeons, we weren't sure how this was going to evolve in terms of trying to understand how to triage urgent versus elective cases. With regard to the outbreak severity, what we thought was the first step as we started to see the hotspots develop was to come up with some sort of a classification system of the severity of the outbreak, and to develop a tiered approach in terms of how we define emergent versus elective, and then the very tough category, which was the urgent cases, in terms of trying to triage them. And we had to really understand the fact that this was going to be different in our region than in Los Angeles, and situations were going to evolve. So even though things started off really bad in San Francisco, they started to settle down. And then we had to come up with a criteria for our case triage. And it was clear to us early on that each case had to be triaged by severity of the disease in terms of urgency. And the urgency issue really, I mean, we knew if it was emergent, it had to go no matter what. But when things were urgent, multiple hours out after we saw a patient, we needed to do something quickly within the next 12 hours or day. That's when things became very difficult in terms of trying to develop a process for triage of the urgent cases in terms of staffing availability, beds, etc., and whether we would have enough ventilators. The other thing that we had to define was the risk to us as surgeons, as well as the staff in the OR. And in the very beginning, we were getting out of the room when patients were being intubated. We were coming back in. It was very dysfunctional. We didn't know how long. It started off, it was 30 minutes, then it was 15 minutes, and then things continued to evolve. And then when COVID testing became fairly routine, we didn't need to stay out of the room. And now we're back to an N95 precaution within 15 minutes of intubation. So there was really a tremendously evolving learning curve here as we were going on. Now, the central issue, I think, in this whole process was to try to understand what was urgent and when we did it. Because, you know, in my definition, neurosurgery is essentially all urgent. You could have a patient with an evolving myelopathy. That's urgent. Certainly a foot drop, herniated disc, a brain tumor, a vascular case. Maybe a peripheral nerve is not urgent. But I think there was, you know, a clear understanding of elective cases, like a carpal tunnel. And then there were all these urgent cases, like these categories. And then there was the super urgent or emergent case, which we had no problem with. And let me try to point this out a little bit better. Now, in the beginning, we used the American College of Surgeons triage mechanism. This was a tiered classification system. If you look at how they did this, we were tier 3. Tier 3 was essentially all of neurosurgery. And so what we were told in the beginning is we didn't postpone anything, and we were able to do all cases right away in the beginning, although this evolved when we shut more and more operating rooms down. And so a meningioma, for example, initially was done, but then after several weeks, and we realized that there was a process of urgency tiering in a way that we could divide those cases out. This was not considered to be in that tier 3 classification. So this could be postponed for a bit. We look at a glioblastoma, we know that this is fairly urgent in the sense that it's not emergent. It doesn't need to go within 12 hours, but certainly if on Decadron, if we can get the patient through 3 to 5 days or a week, we were okay with that. So that was one example. And then we had cases like this, subdural empyema. There was no question that was emergent, that trumped everything else. And we were just going to go ahead and do those cases. So this is kind of how we produced a tier system in the urgent category and then crossed over into emergent, which had to go right away, versus elective. I'm very proud of these 2 articles. It shows us that we took responsibility early on for coming together in a multidisciplinary team and coming up with a strategy that worked exceedingly well, not just with our surgical colleagues, but with our neurologists, our anesthesiologists, et cetera. It was a very all-inclusive process. Okay, so this is how we did it. We, first of all, created, as I mentioned, a multidisciplinary panel, or we called it a surgical committee. This was a group of surgeons, anesthesiologists, interventionalists, nurses, anybody that was doing some sort of procedure that was invasive and interventional, from surgeons to cardiology, et cetera. And we got together and we were meeting every morning, 6 a.m., and coming up with a strategy on how to triage cases. We then added all the aspects of our local government policy or shelter-in-place issues, and we put that in combination with a process where we created a surgical protocol in which, based upon how many cases were in our community and what our actual needs were, we came up with a strategy to move patients in and out of the OR in a very efficient manner that respected the number of ICU beds we had, the PPE that we had, and the needs for follow-up care. We used this process called the Delphi method, which is a process that is used to formalize expert opinions and to reach a consensus amongst each other And then we went back and forth and iterated this over and over and over again until we were able to do this. And this was not a trivial process. There were a lot of us involved, meeting every morning at 6 a.m. and trying to figure this out. But we knew our backs were up against the wall and we had to do something significant. So what was the surgical protocol? In this case, looking at the triage scenario, we knew what was emergent. We knew that those were cases that had to go within 6 hours. And then we broke out the urgent cases to less than a day, like a cauda equina, less than 48 hours, spinal pathological fracture with some compromise in stability or neurologic function or concern about that. And then gliomas or brain tumors that we knew could sit for 3 days, 4 days on steroids and things like that. So we really put this whole thing together very, very nicely. And this is the case triage protocol where we made a table looking at the surge level of the outbreak on the left, from green to yellow to red, which put us in a situation where there were staffing shortages, there was not enough PPE, etc. We were in the red range on a number of occasions, never in black. But we took that and we took it across the board to look at the emergent versus urgent and non-urgent cases and put this all together in this protocol. And then we developed a process where we could create this point value system, as you can see, based upon the surgical risk of the patient, was high, intermediate, or low, or the COVID status. And then if the point total for that given patient was over 2, we know we needed to allocate PPE. And it was this process early on when we were short of PPE that we were able to develop a scoring system that allowed us to clearly allocate the PPE as needed. So this was really, I think, a very important process that allowed us to judge the risk against us versus to our staff with this very important point system. We developed this surgical checklist in order for the case to go, looking at everything from ventilators to implants to the fact of the blood supply. Was the blood ready? Did we have any issues with that at all? And then we had a post-operative checklist in terms of where that patient was going. Did they need an ICU bed, all the way up to discharge? Because if the patient turned COVID positive in the hospital, where were they going to go prior to discharge? So very complicated process. And I would say, you know, this was basically a roller coaster. We had a lot of ups and downs. We had a lot of learning curves, as everybody did. The CDC guidelines, the ACS guidelines did not apply necessarily to neurosurgery. We didn't have enough time to accept a formal based guideline nationally, and so we developed our own. And this is what led to this number of publications with our own institutional protocols. And this allowed us to really develop a framework for surgical triage during the pandemic. So I'm thrilled to be able to share all this information with you, and I just wanted you to know how we here at UCSF developed the process to deal with the COVID crisis. Right now we are in good shape. However, there is a new surge that's evolving our area, and could be within a few weeks things will be back to this protocol system again. Thanks very much, and good luck to all of you during this complicated time.
Thanks so much. I don't see that Mitch was able to join us, so we won't really be able to ask him questions, but there is a question here, and I don't know, Praveen, if you are still here or not, but I think you could probably answer this, and if not, I'll leave it to you, April, because you were also there more. As a health professional, this is from Mary Beth Yosis. As a healthcare professional, it felt so chaotic in the early days in my community. It is comforting to know that there was such cogent, organized, sensible, responsible approaches to the pandemic. Did it ever feel overwhelming or scary for you?
Yes, I think that's a really good question. Initially, because it was unknown what was going on, it was a bit scary. We didn't know what to anticipate. We didn't know if we were going to have enough resources to do the cases in terms of PPE. We didn't even know if our blood supply would be okay because patients stopped coming in to donate blood. So initially, it was the unknown that was really a problem. Over time, we were able to catch up in all these areas. And I think, when the going gets tough, we just have to persevere to take care of the patients. And that's what we ended up doing. But yeah, initially there was the fear of the unknown and we worked through it. And that was the nice thing of having a team around us because we all worked through it together.
I think, go ahead.
Sorry, to add to that too, one of the things that I think we had the advantage of was that a lot of the first COVID cases were actually brought over to UCSF. So a lot of our medical staff and the leaders in the hospital have sort of already had an idea and sort of learned as they went along. And we were, in a sense, ahead of the game compared to some other people who are just getting exposed to all these things. So I think that, in a sense, was the silver lining of us getting the first batch of COVID patients.
I think it was also helpful that the public health departments in the whole greater Bay Area worked together and were the very first people in the country to impose social distancing and shelter in place and to draw attention to the fact that this could be a big problem and to try and lower the curve. And I think that made a huge difference in the Bay Area.
Lisa, I just wanted to introduce Dr. Lawton is here with us today as well. He's going to be co-hosting with you as we move forward with our presentation today. And we'd like to thank Praveen for that answer as well on behalf of Dr. Berger, who is not able to attend today. He has a prior engagement in another city, I believe. Thank you. I'll leave it to you, Lisa.
Thank you. Our next speaker, we are delighted to welcome Dr. Esteban Ortiz Prado. He is from the Universidad de las Americas in Quito, Ecuador, and he's a faculty member there, and he has research interests that are fascinating in high altitude, hypoxia, epidemiology, burns, and global health. And he has done extra studies and traveled the world to become an expert in these areas. And we welcome you and thank you very much for participating, Esteban.
Thank you very much. Yeah, first of all, it's a pleasure for me to be here. Hopefully my English is good enough for you to understand. It's the first time I kind of pre-record my conference, so I didn't know what to expect. It's going to be very short, but I'm going to give you a little bit of the context. Actually, in Ecuador, we got the worst of the pandemic during March and April, and we are actually the country with the highest excess mortality rate in the world in the shortest time as possible. I'm going to just copy a link in the chat room about some of the videos that I helped the New York Times recording for this topic, and I did a really short kind of like topic about like the lack of beds that we had in some part of Ecuador, and that exploded with all of the deaths and the lack of disponibility of people with also neurosurgeries and neurological problems. So if you go ahead with the short video, I'm sure some question might arise. Hello everyone, my name is Esteban Ortiz. I am a public health provider from Ecuador. Thank you very much for the invitation for the Mission Brain Live Symposium. So I'm going to talk about something that is probably not 100% related with neurosurgery and the brain, but I think it's very important to point it out. So we are presenting about what happened in Ecuador due to the COVID-19 pandemic. As you probably are aware, Ecuador was probably the worst hit country at the beginning of the pandemic. Guayaquil, one of the main cities in the country, got hit so hard that we have the excess mortality, the worst toll in the world. So actually per capita, most people die from this part of Ecuador in the shorter period of time. So nevertheless, we are trying to explore during these very few minutes what happened in the country. I'm going to invite you to review. There is a New York Times link about the anatomy of the pandemic in Ecuador, and you can see the videos about what happened there. I also participate in that documentary. But anyway, so the first slide is about like there are no beds in Ecuador. COVID-19 is against the rest of the world. I'm using this title because COVID-19 is taking over the rest of the pathologies in Ecuador. We have dengue, we have Zika, we have other diseases, but as soon as COVID-19 came, everything else was forgotten. I know this sounds kind of crazy, but all of the resources were allocated to diagnosis of COVID-19 and treating COVID-19. In the next slide, you will see that Ecuador, the toll during the outbreak is among the worst in the world. Actually, per capita, the cities in the coast of Ecuador are actually the worst in the world. We have so far more than 35,000 deaths that are exceeding the normal average, right? So in the next slide, I will show you something that is very dramatic. You can see here in the pink bars, you can see this is the excess mortality. This is one part of the city. We have even 666 deaths in one day. And in the entire country, we maxed almost 1,200 deaths in one day. So this amount of people in this very short of time actually, overcome the hospital capacities. And this is the reason of my talk. We have some patients that were waiting for surgeries, patients with brain tumors and patients that were actually in the ICU unit with traumatic brain injury that haven't been able to get medical attention. We don't have the data. I'm sorry for doing that. In Ecuador, data is very hard to obtain, especially kind of like right away. We have to wait at least a year to get the data for 2020. I got some data from some resources that actually are open source in terms of data, but specifically for the other diseases like traumatic brain injury, getting to the hospital, it was very difficult to get. So what happened in Ecuador, you can see in this other slide, you have three SEER mathematical models. And in the first one in the left, you can clearly see that the red dot line is actually the hospital capacity. But in the first week of March and April, we totally overpassed this capacity. And you can see how the number of deaths and number of people getting to the hospital was so much high that people couldn't get medical attention, and that's why so many people die in the streets. Nobody could get even hospital admission or oxygen, and let's talk about ICU units, and the beds were not available for almost anyone. In that part of the country, we couldn't even double the number of beds. After maybe 5 months, we actually maybe multiply by 5 or by 6 the number of beds in other parts of the country. But this is one of the reasons we couldn't get hospital admission, because the capacity was too slow in that sense. And as I told you before, people start dying in the streets, and we were very worried about this because COVID-19 took over. Dengue cases went down so dramatically, but we know that the dengue didn't went down. Actually, the diagnosis went down, and the same happened with other pathologies that couldn't reach the hospital. As you can see in the following slide, where we have the number of people dying per capita, you can see that the Financial Post I think did these graphs where Ecuador is actually top 1 in terms of the total excess mortality per million people, and then it moves around and it becomes the number 3 or 4 until now, which cumulative deaths are still very high. Same in the next slide, you can see Guayas, the province in Ecuador, at that time has more than 14,000 deaths. And that's very dramatic. I think it's the worst hit area in the world in the shortest period of time. Even in New York, you guys have probably 1,000 deaths a day. but the people living in New York is way higher than the people living in Ecuador. So what happened with other pathologies, as you can see in the other slide, I'm just very worried about like brain injury. We published a paper talking about like brain mortality in Ecuador, and Ecuador has one of the highest rates of traumatic brain injury in the world. And we heard from people from all over the neurosurgery and neurological services that these people that were, program for receiving surgeries because of traumatic brain injury or brain tumors didn't receive quite the quality of service that they were expecting. So this is something very short that I wanted to show you. I am not a neurologist. I really like neurology, but I'm not a neurologist, neither a neurosurgeon, but I'm a public health provider. I'm doing a lot of epidemiology, and my PhD will be ending very soon in biomedicine and physiology. I really do something about high altitude physiology, and this is something that is very also important to talk in a further analysis. I just want to thank you for the time to listen to my short presentation. I hope you guys enjoy it, and hopefully you have the chance to see the video that I will try to post it in the link of the symposium. Thank you very much, and have a great talk.
Thank you so much. I'm sorry your slides did not come out here. We will make sure that they are included in the recording.
No, I'm sorry. You have to see my face all the time. So I think that works. But yeah, thank you for listening. I think it was very important. The context of managing a new pandemic in a developing country is way different, right? We also like to thank, the US also provided some support in the worst time that we got, and some other countries did as well. We were, it was so sad seeing people dying in the streets. People, I think, and this is my guess, I don't know, we could avoid those almost 1,200 deaths a day during the first maybe 4 weeks of the worst of the outbreak, just if we couldn't have some oxygen at least. In some point, people didn't get any oxygen. People was afraid because 100 bodies are lost because they died, they were burned, and nobody knew who was there. So people was afraid of sending people to the hospitals. And I think this is a global talk. You guys are a worldwide recognized organization, and I think you are very most aware about all of these issues. But sometimes it is important to show the other reality when capabilities are not the same. And it was definitely very hard. And, actually, we're doing pretty well right now. And, people talks about this herd immunity, which I don't like to say like about that. But in people in Ecuador, the contagion was so big that I'm seeing people just, we almost return to the normal mobility, and people is not dying anymore. So we did reach herd immunity around 40%, and the other 60% is protected by, mask, social distancing. And of course, we keep getting cases every day, but the ICU units are already relaxed and receiving other patients. So hopefully you enjoy it. And if you have any question, please let me know. And an extra, if you need high altitude data about, whatever, in Ecuador is one of the good countries to do it, because we have from 0 to 4,500 meters in elevation. And, I'm sorry, I'm using this time to share our country for you to do some research with us. Thank you very much.
Wonderful. We had a trip to Ecuador planned for this year, but obviously it's not happening. We have only, not a real question, but we do have one anonymous attendee put on our question page. Your English is perfect, and we didn't mind seeing your handsome face 100% of the presentation.
Thank you very much.
But thank you. It was wonderful to see this perspective. Michael, did you have any thoughts?
You mean my final thoughts?
This talk, and then you get to go to your final thoughts.
No, I didn't have anything more. Just thank you for sharing your experience, and very nice presentation.
Thank you very much.
Thank you so much. Okay, next up is Michael Lawton, and he will be closing. Michael's the Vice President of Mission Brain. He's also the President and CEO of the Barrow Neurological Institute in Phoenix, Arizona, and used to be my boss. Hey, Lawton.
What's up, Hannigan? It's good to see you.
Okay, go ahead.
Okay, enough of that, huh? You don't want to get me started. All right, let's see. I'm going to screen share here. Do I have your permission?
Do we not have yours yet? No.
No, I'm doing it live. I didn't get a chance to record it, but hopefully you'll now see my slides.
Yes, we do.
Okay. Well, so we're way over time, so I will try and keep this brief, but there were a couple of things I did want to say about our response here, how we've seen this pandemic and what initiatives we took. So just very briefly, I like to think of this as the 3 S's. We wanted to make sure we maintained our service. We had to be concerned about safety, and we wanted to be supportive of those that depended on us. And so with regards to neurosurgery, we really wanted to continue to serve the Phoenix community. We had to, we viewed that as our duty. This is just a graph of one of our COVID publications showing, like all the other speakers, our volume was basically cut in half. And we had a decrease in the consults that we saw in the ER, the cases that were getting to the OR. But we continued to provide the care that we needed to handle the emergent and urgent cases. And we also felt the need to continue to train residents. It's obviously our duty not only to serve the patients, but to serve the residents. And we felt that was something that we needed to continue. So we did maintain an operations at about 50%. For me personally, it was about 65%. And one of the things that was really important was just to continue all of the stuff, all the initiatives that we had started. This is a picture of our building, and our parent organization wanted to shut everything down system-wide across the country, including our erection of this building. And we had to be creative about moving money and providing financial support to keep this project alive. And we did. You can see this is a photo from last week. The glass is up, the building's up, and this all happened in this interval from the pandemic when it started in March to now. So that was, I think, an important thing, is just to not lose sight of all of the efforts that go into initiatives that need to be maintained. Now, one of the things I was really proud of was just seeing my residents spring to action. And one of their biggest concerns was safety. And so what you're seeing in this slide is a picture from the Barrow Innovation Center. And the residents run this innovation center. They take ideas that come to them on cases and on the service, and they develop devices. And this is an example of them building a better mousetrap, or in this case, a N95 mask. And they prototype these out of 3D printers. They put the silicone around it so that the nurses and the doctors wouldn't get the abrasions on the face, and we're creative about getting the filtering devices and produce these, mass produce these faces, these face masks. And you can see here, this was unveiling all of these different masks to the St. Joseph's BNI hospital. We even had Martha McSally here, one of our state senators, come and pick up these masks and take them up to the Indian reservations, where we had one of the hardest hit areas in the country with COVID. So it really, I think, was a great example of how residents, and here you can see Michael Bowl in the foreground. He was our chief resident. He and his team really took this on and made this happen. And it didn't stop there. This is the COVID Claw, which is a little device that helps push elevator buttons or open doorknobs without actually touching the metal. I'm showing it being used as a bottle opener, but it's actually for use as these door and knob pushers. What I want to finish with, though, is this idea of supporting people even as the world changes before us. And you know, we did our thing to support the hospital. We gave up our ICU. We have a 64-bed ICU at Barrow, and we gave it all up. And we were literally back in the ICU, the 16-bed ICU that I trained in as a resident, which is in a different building. It's not in the neurosciences tower, but we gave up our ICU because it had the most modern facility. It had negative pressure. It had all the bells and whistles for ventilators. And we wanted to support the effort. So we gave up our conveniences and did that. One of the things that was really valuable was medical memory, which is a video app, so that when patients were not allowed in the hospital, not patients, sorry, the patients' families were not allowed in the hospital, they were still connected to the nurses and the physicians through this medical memory system, where we can record an update, we can record a conversation and then post it to them, so they could literally have face-to-face contact with us as the providers. One of the things that went away was these afternoon teaching rounds, which we do daily. And we have a good time there. And what became of that was what you see in the lower right, which is basically these Zoom conferences where it would literally be me, my resident, and my fellow in our auditorium with all the residents Zooming in. And that's how we maintained our conference schedule. Everybody's talked about this, the whole proliferation of webinars and all of these conferences. And I think that's been interesting to watch. It's, I think, been a little crazy. Everybody and their brother and sister are doing these, and it's gotten to the point where there's oversaturation and you don't know what to do. But through it all, I think some interesting things have emerged. Our Grand Rounds is now fully digital, which means that I can invite anybody I want. I call them up, they Zoom in, and we can get them on the stage in Phoenix in the Zoom format. So it's very easy to have a really nice spectrum of speakers without having visiting professor dinners and the expenses of travel and the time and so forth. So this has been a really nice change. Another interesting thing for me has been this whole co-videos effort that we've done. The idea was, if residents aren't getting enough cases because the volume's down, let's post our videos that we are doing and try and let them stay engaged that way. And this has been really exciting. We're up to 90 videos on the site. I've enjoyed seeing the people respond to this because I can see I can see people when I post on social media liking the stuff and retweeting the stuff. So it's taught me that you can really connect with a broad audience almost instantaneously by manufacturing these videos, which is really just capturing what we do anyways on a day-to-day basis and reformatting things slightly and then producing. It's essentially turning our workshop into a studio. And it's an amazing thing to witness, because when I reflect on how things were pre-COVID, we'd have to go through peer review to get a video paper published, and it would be weeks or months of review and then revisions and then the delays in actually getting it on the site. This way, I do a case yesterday, my resident or fellow edits it that night, I narrate it the next morning, and it's online within 24 hours. And it's really an amazing power to realize that we have at our fingertips. As we've tinkered with this whole educational format, we've come to this, we call it Barrow Basecamp, and we can essentially review game tape, which is operative video from the operating room that day. We pull it into our teaching sessions. I can telestrate it, as you can see here on this video, and it becomes this way to teach. So this is our first episode of Barrow Basecamp, and this is just a little intro piece. But what we do during the as it buckles laterally during these episodes, we can discuss the cases. We can talk about all of these different pathologies, how we would best treat them, and then we can capture all of this teaching that's happening in our rounds. And you can see we've made this like a little show, so you can see the individual cases, the videos, and how we bring it all together. This is a bypass case, so here's some bypass footage. But see how these come together really nicely. Anyway, this is something that we've come to, and it'll be interesting to see how that works. So that's kind of what I wanted to show you. There's an expression, never let a crisis go to waste. And I think what we've done is to try and convert this pandemic into an opportunity. And just to conclude this, there are incredible opportunities to connect and teach despite the pandemic. We may not be able to be with one another, but we can still connect. We can still find these ways of circulating knowledge and ideas. And that to me is really what makes this this position that I'm in and this role that we're playing here so valuable. It's changing the future of publishing before our very eyes. And I think this whole idea of going from idea to dissemination instantaneously is really transformational. I think that there's so many more ideas that we're playing with here that we can develop. And I think as the world moves more virtual, we really are disrupting neurosurgical conventions. And I think that's what's exciting. So that's my closing remarks. I just need to thank Lisa, April, Alfredo, Will, Rodrigo, all of the people that you've seen before you, and many of the people that you haven't seen before you that are tuned into this seminar. This has been a journey. I don't know how many years we've been at it, but it's probably close to a decade. Our first logo is there in the upper left, and this is our current version of that. And you can see how it's evolving, it's exciting. I think we're doing a really good service for the world. And hopefully we continue to attract the talent and the humanitarian spirit that will keep Mission Brain thriving in the years ahead. So with that, I'm going to stop my share and turn this back to you, Lisa.
Okay, I don't see any other questions. I don't see any other questions. Thank you to everyone for being here. Or April, did you have a question?
There is a comment here. I guess this is from Dr. Legospi. It's always an experience to hear you. Michael, thanks for these great insights. If you want to respond to that,
yeah,
Michael,
I'll respond. Gab, thank you so much. I was trying to put together a talk, and I looked at some of our pictures from the Philippine missions, and it's so great to see those. It's so great to have you on board with this, and just see how the whole Philippine mission has expanded with Mitch's work. I think it's great. It just shows how this organization really is boundless, and the more people we can bring into the fold, and the more resources we're able to pull in, I think the wider we can spread, and it's exciting to see that.
And there's another comment here. This is from Sengu Han, your former resident. Says, thank you, MTL. You're truly a generational talent.
Well, thank you. It's nice to get compliments from residents when they're no longer my residents. So I appreciate that, Sengu.
And as Lisa alluded to, there's just one thing that I think we need to wrap up. There was a question about vaccines. If our panelists would like to respond, if any of you are doing any kind of vaccine trials in your institutions at this point.
I'll speak for mine. We are not. I think that's become an industry and pharmaceutical endeavor, and we don't have any role that we're playing. We certainly will embrace those that come and get them to our frontline workers, but I don't have any inside knowledge on that.
I think there was a note from Dr. Legospi in the Philippines that there will be one of the centers for a vaccine trial in the Philippines once that gets started.
Oh, yeah. Yeah, hi. Good evening, everyone. Well, good morning. The Philippine General Hospital is going to be the site of the trials that are coming in. I think there are 3 or 4 from China, Russia, and some of the European companies. So we will be the lead center for all of these trials, and we're excited to contribute in any way into partly solving this pandemic. So my work as a neurosurgeon is expanding to infectious diseases, and sometimes I'm getting confused already during the day which is which. But it's exciting.
Great. Thanks for the insight, Cap. Very nice information, especially for those who are attending from the Philippines. And I think that's it. Lisa, Michael?
I think that's it.
I think that's it. We're an hour over time. So thanks to those who attended and stayed with us to the bitter end. And congratulations to you all for pulling this off. This was really remarkable.
Thank you, everybody. Thanks, and have a great day. Stay safe and healthy.
Thank you. Bye-bye.
Bye-bye.